RV pressures, right. The next part of pathophysiology is, hence VSD is silent, and when VSD is silent, right ventricle into pulmonic artery crosses pulmonic stenosis producing ejection systolic murmur. So what you hear is a systolic murmur in tautology of fellow, not from a VSD. Next comes what? This is most important. The more severe the pulmonic stenosis, the bigger right to right shunt is, less flow into pulmonic artery and shorter is the ejection systolic murmur of pulmonic stenosis. And this thing is very, very important in tautology of fellow is, and the shorter the ejection systolic murmur, the more cyanosis because of less flow into the lungs. So it's better to have a harsher murmur than a soft, shorter systolic murmur of pulmonic stenosis. And that's why when the child weeps, when the preload increases, the more chances of getting this child into apneic spells. Hence, the severity of PS is directly proportional to degree of cyanosis, and the intensity of systolic murmur is inversely related to pulmonic stenosis. If you don't hear a murmur in a newborn with tautology of fellow for pulmonic stenosis, your ear should start ringing. And I'll show you a couple of examples in my subsequent slide. So one of the physiological characteristic feature of TOF is RVOT obstruction can fluctuate. Any individual with minimal cyanosis can develop dynamic increase in RVOT obstruction with subsequent increase in right to left shunt and cyanosis and leading to hypercyanotic or TET spells. Typical spell begins with a progressive increase in rate and depth of respiration, culminates in paroxysmal hyperapnea, deepening cyanosis, limpiness, syncope, occasionally as a convulsion, stroke and death. Peak incidence is between 2nd to 6th month of life. Spells typically initiate by stress of a feeding, crying or bowel movements, particularly after awakening from a deep sleep. Amongst all these things, possibly the feeding and crying is the most important thing amongst child. The bowel, because they automatically move, they are not bothered for the bowels. And when these child are cyanotic, the mothers gets tired all the time. The more the mother gets tired, the more the incidence of cyanotic spells are. So this is one of the picture I have taken from the literature. Spasm of RVOT, right to left shunt, decreased PaO2, CO2, pH, hyperapnea, increased systemic venous return and increased RV, right to left shunts. So issue is the child should be as calm as possible. And second thing is, don't scan a child when the child is irritated and weeping to a large extent. The fair chances, the more you will scan, the more chances of having that child going into the apneic spells. And we always have a habit of running around, and when we find a child, we want to scan him or her as soon as possible. The more the child cries, the more efforts we'll make to do a diagnosis. So various explanation, I'm not going to go into this theories of cyanotic spells. A little word about managements, because this is more important. Like it happens to many lab when we are scanning these kind of a thing. We should be prepared if we are doing a pediatric lab. So you should be prepared like how to manage these kids in your lab or in your center when you are doing an echocardiography. And that's what, like I work in a small center, so I know like I have to deal with each and everything. I told you yesterday I gave a contrast to a lady who had a left side contrast, and she had an unroofed coronary sinus and she collapsed. So people talk of a nightmare in cath lab. I can tell you nightmare in echo labs. Patient, you are doing a dobutamine, suddenly goes into ventricular tachycardias. Tight LED lesion, walks for a certain distance and suddenly get breathless, 6 millimeter of ST segment depression. That's what exactly, you have to be very, very cautious. People says like I've seen number of corporate hospital technician doing a TMT and the doctor is not available. And when the patient always complain, look, the patient collapsed on a treadmill. I have a literature in my patient was there, like who was very critical. When I walked for certain distance, I fell down. We did a treadmill, 150 heart rate, dropping down to 70, and he virtually fell down. We pulled him on a table. He was a proximal RC disease. He was a severe bradycardia, complete heart block. Took him to, like, stabilize him, took him to cath lab and did a coronary angiogram right as origin, at the origin was blocked. So you have to be very careful when you are doing an echo. Echo is not a simple thing as on more today. Except for the patient who are coming for a routine checkup, rest of them are all potential troublemakers. So this is the list of all things, and you should have a propranolol in your lab when you are doing an echocardiography. Morphine, of course, is not available even today, but the best part is the squatting position, which they really helps you a lot. And this is the various posture with which the patients they gets benefited when they have a spells. And as we started on the first day, we said we are not going to talk only of pediatric echocardiography, we are going to talk of pediatric clinical echocardiography. So, little bit on the clinical features: wide due to variable symptoms, RV flow tract obstruction, ultrasound at fetal echocardiogram, newborn infant cyanosis and systolic MUR, acyanotic TAF, rarely CHF unless there is a large PD or aortopulmonary collaterals. Pregnancy is a poorly tolerated if they have this kind of a things. Examinations, all of us knows, I am not going to detail of this examination, but most important thing is look at a cyanosis, look at a clubbing. I was looking at Dr. Neeraj. I felt very happy when he said, look, I saw his nails appears to be clubbing. At the same time, I've seen in many hospitals, like I've worked for a Fortis, I see like cardiologist will come, child is lying down on a table, he'll put a probe, oh, nothing is there, send him off. So the clinical examination really makes a lot of difference in these populations. ECG is very important, and when we look at in the ECG, we make a lot of positive things, especially this RBB kind of a pattern, RSR type of a pattern, which is seen over here, and this is what is almost looks like the same as we look at other things. But the most important part is an axis of this RVH. I am going to talk about little bit on axis on ECG. That's going to be in there a couple of minutes. X-ray chest, nothing to say about X-ray chest. If you look at an X-ray chest itself, you will come to know about that patient has got a boot-shaped heart. It's suggestive of TOF, not exactly of TOF. That's how I always say. Echocardiography is a cornerstone for all these kind of abnormalities. Here is classical overriding of aorta. What overriding is? When this part of interventricular septum overrides the aorta to almost 50% or more, that is classically of overriding of aorta. And there is evidence of a large VSD, and majority of this blood, because of pulmonic stenosis, is drained from RV to LV to aorta. So there is no shunt in between, it's virtually the equalization of pressure and driving to this. And if you get rid of this septum completely, the tetralogy of Fallot converts to other pathologies. That is morphological right or left ventricle, dependent on how the structure has developed over a period of time. Then comes, this is the most important thing. Yesterday I was talking, and today morning I was talking. Concentrate on this aorta and short axis always. If I happen to get a patient, I'll show you, like that's how I scan this short axis view is. If I'll draw a patient in Plaque's window, this aorta would be right into the center of this image. And once you rotate, this aorta will come right into the center, pulmonic artery over here, the RV is on this side. So bring your image as up as possible, get rid of this mid and apical septum so that you only see the proximal half of 1/3 of anterior septum, 1/3 of posterior wall, and aorta is right horizontal in the center, and drawing the line in the center, the aorta intersection is present, which gives rise to aortic valve opening as a typical rectangular box. And once you go from that to 90-degree rotation, the aorta will be back into the center. And if you look at that aorta in the center, you will be able to come to know where this VSD is. And how I really depend on VSD is, this is the most important thing in short axis that really tells me where my VSD is. And in this image, here is the VSD and here is this turbulence at pulmonic artery levels. And if I really switch on the next image, look, it is thickened, mobile but restricted opening of aortic tricuspid valve, pulmonic valve with bifurcation which is seen very clearly. This is what exactly I image. I said right into the center, if you draw a line right into is cutting across the aortic valve. And try to make this image, you will get enough knowledge what exactly are we looking in. In pediatric population, is damn easy to make images rather than adult populations. And once you switch on a Doppler, we get a gradient of almost 30 millimeters in this, maybe more, but pulmonic stenosis is present. This is another like where we have an associated PFO or ASD. I'll preferably say a PFO, it's not a Raj Hughes defect which is seen over here. And we have an associated right ventricular hypertrophy seen over here. Demonstration of coronary arteries are very important. We'll try to demonstrate in case the patient, will get that patient back today. And that is what, how I said right and left coronary arteries, that is the most important part, apart from these 4 important features for tetralogy of Fallot. Cardiac catheterization, we do need a cardiac catheterization for number of these particular things. And I'm sure, like, I don't do it, Neeraj is an expert for that, he's going to dwell a little bit on this particular cardiac catheterizations. And the course and the complexion, I want to show the slides, like this is what if we don't take care of them, and when to operate and when not to operate. Each anoxic spell is potentially fatal: polycythemia, cerebral vascular thrombosis, anoxic infarction of brain, and neurological complications. And many things which are possible in these people, and they really suffer with them. Dr. Munish Tomar showed yesterday one of the slide where she had the lady, the child had the cerebral abscess. So these are all complications of paradoxical emboli, cerebral thrombosis, cerebral abscess, seizure, hypoxic damage, endocarditis and vegetation, and postoperative strokes. And if you have a patient of a tetralogy of Fallot, I'll show in a couple of minutes, based on the severity, at what level we should operate, but all of them should be operated within 6 months of our birth. Don't leave them on a chance, because the chances of these complications are very, very high. This is one slide I have downloaded summarizing the natural history of a Fallot's tetralogy. If you leave them, what exactly happened? The slide starts from here, like on birth. Look at the severe cyanosis at 3 to 12 months, 15% cyanosis after 1 month, then 40%, 45% hypoxic smell, CVA, brain abscess, CCF, and now the survival is only 44% at 10 years, 10% at 20 years, 1% at 30 years, and less than 1% at 40 years. And as a cardiologist, as a physician, I feel sometimes we have a responsibility. When our responsibilities are over, we have a responsibility. We should help these child to get their surgery done. And we can contribute a little bit from our income also if we have to do something good for somebody. मंदिर, मस्जिद, गुरुद्वारे में भी तो हम डोनेट करते हैं. ये जो मंदिर है, मस्जिद है, गुरुद्वारा है, उन सबसे बड़ा है ये। This is one slide I've made. Like, that's how like I prefer to do it if I get it off and try to follow the child up. Immediate, within few weeks of birth, very severe RVOT obstruction with saturation less than 70%. TOF with PA with saturation with less than 70%. It's a red herring as soon as possible, ASAP. Corrective surgery by 2 to 4 months, moderately severe stenosis, marked cyanosis, saturation 70 to 90%. And corrective surgery should be performed in all TOF within 6 months of birth. Push them up, and you have to push them really hard. Yesterday we have been pushing, look, it's not, we did not call for demonstration. We have been pushing that lady, look how we can really push you to get your surgery done. If I'll say the same thing, you'll say the same thing, you'll say the same thing, you'll say the same thing, their mind starts thinking. When you go out for a shopping, first 2 shops are really bad. Third shops start satisfying you, and you buy ultimately at the 4th or 5th shops. So you have to show them to multiple people, look, no, you need surgery, and why you need surgeries is, वो पहली शॉप पे बोलते हैं डॉक्टर ने डरा दिया, ये हो जाएगा, ये हो जाएगा, ये हो जाएगा. सेकंड शॉप तक पहुंचते पहुंचते कंफर्टेबल होते हैं. 5th शॉप पर वो एग्री कर जाते हैं, डॉक्टर साहब डराया नहीं, बताया था. Contraindication for repair LED from RCA crossing over to infundibulum. You have to tell a surgeon, look, this is what exactly. Severe hypoplastic PA and then pulmonary atresia. And then we need a palliative procedure before we do a corrective surgery. So my field is little less than that. So once I make a diagnosis, hand over to pediatric cardiologist, they hand over to surgeon and then make a diagnosis, what's to be done, what not to be done. Multiple things like which is there in surgical treatments and palliative surgery. Post-operative, couple of very important things we need to, like people come for a post-operative period. Current surgical repair, even less than 3 months old infant, is excellent. Hospital in 1 month survival rate is almost 100%. Primary repair should always be considered. 20% survival after primary surgery is almost close to 100%. So we are giving back a mother as good a child as a normal child is. So you have to do a lot of, and what all you should look for once a corrective surgery is done. I have got a couple of examples for that also. Residual VSD, pulmonary regurgitation, residual RVOT gradient, RV wall thickening abnormality, RV failure and dysfunction, atrial tachycardia and ventricular tachycardia. So you should be aware when the patient is coming to you. Look, this is all I have to look for once the patient is coming back from TOF repair. So work is not easy, pediatrics, I'm sure about it. Vivek will say it's better to do angioplasty rather than doing a pediatric echo. Now I'm switching over gears a little bit before I hand over my mic to Dr. Neeraj. This is RVH on ECG, axis between 90 to 150, then possibly you are looking for a TOF. DORV, QRS axis more than 150, resemblance almost to TOF, but systolic murmur along left sternal bottom. And if you have an axis, QRS is with 30 to minus 60, that's left axis, that's tricuspid atresia, and DORV almost resemblance to TOF. So my quest of showing this slide is, look, you have to depend a lot on axis to differentiate between various modalities or various variabilities of tetralogy of Fallot's tetralogies. So X-ray chest, ECG, clinical examination and a pulse oximeter along with an echocardiography will help you come to a correct diagnosis of TOF. So I'll put a stop over here and I'll hand over mic for continuing the pathophysiology process of TOF into DORV, into TGA, into various other modalities which Dr. Neeraj is going to dwell with. And I'm sure it will be a good learning for all of you. Like how do we differentiate TOF with other pathophysiology? Even I want to learn number of times. Look, and that book, if somebody has not bought it, believe my book, that book is very good. I often refer to that book number of times. And it's not a book, as Dr. Munish said, it's an atlas kind of a thing. You know, like you look at the images and realize what exactly. And it's a complete comprehensive evaluations. Now 10-year-old, it's not a new one, it's a 10-year-old book, but it's very useful number of times. For me, Harrison is still very good. For me, Braunwald is still very good. If you read in a Harrison, you read in a Braunwald, even one line makes lot of sense even today also. You read as many times, you will read a new thing. So, like this kind of pediatric books, they become really raffle books for. Otherwise, you can read Anderson and another word. This all depends on you. So, I'll stop. Thank you very much for patience hearing. I'm sure we will get benefited with this kind of presentation. I must change that. Any questions before Dr. Neeraj takes over?
So what is the mechanism that squatting helps? What is the mechanism that squatting helps in the
Squatting helps. What exactly is happening? Lot of venous flow is coming back to the. So squatting helps in reducing the venous flow.
venous flow?
Increasing the SVR.
Increases the SVR.
I don't know whether you have seen in your life or not. Many people of my life, when they are in LVF, you know, like in the night they'll tell you, sir, we get up and sit, we feel better. Sweating will increase or reduce the venous flow? Systemic vascular resistance. Systemic vascular resistance, SVR.
Basically, right to left shift decreases.
So what happens is in cough, in spell, let us go to this box.
Yeah.
अच्छा है सर के मेरे हेड सेम है ना तो वी आर कंफर्टेबल विद ईच अदर
नहीं मैं ये हमारे साइज का है इतना छोटा सा है तो हाथ में नहीं आता एक हमारी फर्टिलिटी में एक डॉक्टर विजय राघवन है
ओके
हाँ चेक करना है
डॉक्टर विजय राघवन इज इन केरला इंस्टीट्यूट ऑफ मेडिकल साइंसेज किम्स में आजकल काम कर रहे हैं त्रिवेंद्रम को वेरी इंटेलिजेंट पर्सन unbelievably intelligent person. He was a professor of cardiology at this thing, Trivandrum. And his height is hardly 8 inches or 9 inches. And people say he's like a hand pump. Whatever is seen outside the heart is over 100 times down inside the heart as far as knowledge is concerned. You listen to him for right-sided cardiomyopathy, you listen to him for pericardium. He'll tell you just basic how this pericardial fluid will collect, what is the interpericardial like volumes.
Vijay Raghavan also for
What will be?
endomyocardial fibrosis.
Endomyocardial fibrosis. Absolutely deep knowledge. And when he will not know, he'll raise his hand, Rakesh, I'm sorry. I sent him recently a clip where the aortic valve was prolapsing during inspiration. And I had not seen in my life, I've got a recording in my hand. With every inspiration, the aortic was prolapsing back into the LV. I sent it to many people, look, I need to know how these things are happening. And everybody started raising their hand, look, we do not know how this is. And Dr. Vijay Raghavan called me up. He was the only person who called me up. Rakesh, आज तूने मेरे को हरा दिया. I said, it's not a question of हारना और जीतना. I did not understand anything, so I thought, let me ask you, so that I increase my knowledge also. Somebody was saying like we can learn everything. I think we can not learn anything till we die. And we have to keep on learning everything every day. Every patient is a challenge for us. Four days down the line, I had a patient of CABG, post CABG, came in complete heart block, took him, we did a pacing, stabilized. He was in LVF, we started the decongestive therapy. And third day he was in anuria. Creatinine 2.68 to 3.8, 3.9. Now, what to do? I said to my interventional, I said, open up his PDA. His PDA was almost blocked. He said, no, I'm not going to do it. 3.8 creatinine, I don't want to take a chance, like just put a pacemaker. Then we sat down, me and an interventional colleague, we sat down and along with intensivist, and then we realized that patient was over judicious use of diuretics and septicemia. Procal was almost 0.7, 0.8. We changed the antibiotic, gave IV fluid, settled him down, and now started pouring urine back again. And a very high profile family, the more high profile families, the more the troubles are. 10 people you will have a phone number with you, and all of them will keep on calling you one after another, one after another, one after another. So let's start.
Okay, sure.
And let's show this common anomalies of a great vessel oxygen.
First, this diagram for TOF, like we have TOF here, and
Focus on this now.
okay, now this is a VSD and PS. We're talking about TOF spell, suppose. So what happens in flow? The blood flow from RV to PA or LV to aorta depends on what structures, what is the basic reason, pathophysiology. What will decide? Resistance. The vascular resistance will decide, not BP. The flow will depend on the resistance. Suppose I have SVR, that is called SVR, this is called PVR. If PVR is higher than SVR, the blood will go from right to left. If SVR is high, so the blood sitting here or sitting here drop has to be given a way out. Like if this is the RBC in the RV, you want this to go to the PA, then the PVR has to be low. If you want this to go to this side, the SVR has to be low. If you have a TOF patient, how does the spell mechanism works and how does this abort is basically this phenomena of SVR and PVR only. But additionally, here is you have an infundibular spasm. The anatomical obstruction is also there. There is no valve. The blood cannot go irrespective of PVR. So there are two mechanisms. One is obstruction, obviously, and then resistance. Now this obstruction you can go away by beta blockers, by metabolic acidosis correction. But how do the posture helps? By increasing the SVR. You increase this, the blood drop RBC would go towards this side. So any mechanism where you increase the SVR will help you in the reduction of the cyanosis and the spell. So this is one mechanism where you have a squatting things happening, and then here you are talking about PVR and muscle spasm. PVR you cannot modify in TOF because in TOF PVR is always low. So you can't go further low in PVR. So that you can't modify. You can't modify this factor and this factor. So you can modify the spasm and you can modify the SVR. Let us go ahead with this plan. Okay. So common anomalies of gate vessels origin. So what are gate vessels we have today? How many? Two. We all have two? Great. Because we should have two vessels, otherwise difficult. Life is difficult. So that means there is anomaly where you have one vessel. 3 is not possible. I have not seen a 3 vessels, but there are possibility. Markers are different. Okay. So if you have one vessel, suppose there is a one outlet only, what are the possibilities? That we have to know. Once you start doing echo, you are seeing only one outlet. What are the possibilities? Truncus is one. Yes, very good. Truncus. Then? Very good. Pulmonary atresia. Then? Opposite of pulmonary atresia? It's easy, no? Aortic atresia. So we are talking about 3 vessels only. One of them we have to confirm. Truncus, pulmonary atresia, aortic atresia. So we'll go to with this phenomena and then other phenomena. So you have great, you can have full screen. Okay. Truncus, atresia. Then what are other anomalies where you have 2 valves? Suppose you have 2 valves. What are those anomalies? One is reverse, as you understand. So RV is giving rise to aorta and this is giving rise to PA. How to identify, I will come back, but first we understand what are the possibilities. Then DOR, where we are considering is the override is more towards one side, which is calling is DORV. And the third anomaly is hemitruncus is really not a vessel or great vessel anomaly, but it is great. Hemitruncus means RV is giving rise to PA, aorta is giving rise to one of the PAs, either RP or LPA. So RV is giving rise to PA, but it is not dividing, and this aorta is dividing because this is giving rise to other PA. It is RPA, then this is LPA, this is LPA, then this is RPA. You understood this point? This is called hemitruncus or PA from aorta, one of the branch PA from the aorta. This is the spectrum available to us, which are we have to identify. So if you can identify these anomalies, you can identify TGA, you can identify hemitruncus, you can identify truncus, pulmonary atresia, aortic atresia. So the most common anomalies of outflow tracts are these only. The last I have written TGA with TAPVC combinations, TGA with TAPVC, TOF with APW, TOF with AP window, double arch, coarctation, interruption, they are different spectrum. TGA with TAPVC, I have seen only one case. You can find an article in my name also. This is a very rare report and I have reported this case, but I will try to show if I have today. But that is not really not for the beginners, that is for the late. So if you talk about single semilunar valve, truncus, single semilunar valve, truncus or pulmonary atresia or aortic atresia. How? Truncus arteriosus means single valve giving origin to aorta, PA and coronaries. So you have to demonstrate all structures coming from this vessel. I have to demonstrate everything coming from this vessel, PA, coronaries and aorta. Only then I can label it as a truncus, otherwise I can't label it. If I can't define PA, I can't call it truncus. If I don't see a coronary from this vessel, I can't call this truncus. Then this is I am talking about maybe pulmonary atresia, because pulmonary atresia also a single valve and will give rise to pulmonary arteries. Aorta will be coming somewhere else from the LV. So pulmonary atresia and truncus are difficult to differentiate. Let us come to the picture now. So again, single valve means truncus, pulmonary aortic atresia, and 2 valves means TGA, AP window, DORV, hemitruncus, double arch. Now come back to the imaging part. So this is an image of truncus I am trying to show now. So you can see the ventricle and one outflow. All if you can appreciate this outflow. I don't know why I am not, it runs on my screen but it does not run there. Display settings. Okay, so focus on this part first. This is the 2 ventricles subcostal view, and you can see one vessel and then I see another vessel here. See this? So you see 2 vessels. So this may be TGA coming because the vessel is dividing and coming from LVA, but I know there is only one valve. When I see only one valve, I am not talking about TGA. So, I am talking about this vessel, either truncus or pulmonary atresia or aortic atresia, where one other outflow is not seen. Now, if I can see one vessel going into the arch and the other vessel is going into the towards the other way, that means I have demonstrated aorta, and you see the coronaries here. So, aorta, coronary and PA. If you can demonstrate all three structures, then this is a truncus. Go slightly anterior, I am trying to see other vessel, I am not seeing another vessel, I am seeing only one vessel, one valve and one vessel. So, I am thinking this is maybe a truncus arteriosus. Let us see other views. Same view, see the color. Now, you can see one vessel, 2 and 3. So, maybe this is the PA dividing into two parts and this is the aorta, and coronary we have seen the 2D. Got it? So, when what I am trying to say here is, when you see a vessel dividing from LV, this is not necessarily a TGA. This can be truncus, because first thing is you have demonstrate two semilunar valves. If there is only one semilunar valve, I am not talking about TGA. Now, see the other short axis view, how does it look?
So RV is a blind spot.
No, RV is always there. I have not shown the RV because it is a two ventricle, no? There are two ventricles. We are focusing on the LV side, that is why. RV is there. Truncus arteriosus RV is normal. Normal. It is a two ventricle disease, not a single ventricle disease. And then you see the PA here, the aorta and PA. So, what I say when I see this aorta and PA and single valve, normal related to great vessels almost, then you are talking about a truncus. One more point in truncus is, I told yesterday also, reversal in the arch. This is the arch view, this is the reversal. You can see the red flow. So, if I come to the truncus here, so that means coronary here and PAs somewhere. There are variants of truncus depending on variety, PA may be differently placed, but the blood to the PA will come from here, and also reversal happens because there is a shunt here which has low pressures. So, the blood will go back also in the truncus like this patient. So, you see the reversal in the arch because PA is proximally located, and that is why when you see a PA and reversal in the arch, start thinking of truncus also. So, one semilunar valve and you are thinking of truncus arteriosus. So, what is the structure behind aorta? Yesterday we discussed this part. No, behind the aorta vessel, artery. Artery behind the aorta, PA. Mostly RPA. So, when you see arch, you mostly you have RPA. Now, another structure is atresia, valve, pulmonary atresia. How do you differentiate? See this structure, and but I am seeing a valvular structure here. See this? Can you appreciate this structure? So, always in pulmonary atresia, when there is no valve, tissue is always there. Tissue is always there. It is not that there is no valve there. So, you can see the valve here, but this is not functional. So, that is valvular atresia. Sometimes you have long segment atresia, but then this will not give rise to, this structure will not give rise to coronaries. This is another long segment pulmonary atresia. See this group of atresias, this is the VSD, and you do not see a forward flow here. Oh, cursor is not moving. Okay. So, this is the VSD, and you do not see a antegrade flow across the RVT. Color is not showing any flow. See this. Now, I will go slow. And this is the, some sir was asking me yesterday, vertical PDA. This is the vertical PDA. See suprasternal view, and you see a vertical PDA. In pulmonary atresia groups, the PDAs are mostly seen from the suprasternal view better than short axis view. See the PDA here from aorta to PDA. I will go back one slide and then let us see this now. Yes, you can see the vertical PDA, and this is the VSD, and there is no forward flow, there is no valve. So this structure, so in this structure, pulmonary atresia group, what is the vessel outflow? What is the outflow here? So truncus, we say all structures have to come from this structure thing. Now in pulmonary atresia, aorta is coming, pulmonary valve is not there, and this is PDA, and then PDA supplies the branch pulmonary arteries. But you will not say a connection from RV to PA. Okay. Now we have to define this is the PDA, and then you see a bifurcation like this. So most of the times this is a difficult decision to differentiate truncus versus pulmonary atresia, because you need all the structures to be defined from aorta to coronary to PS. But if you say I have one vessel, I start thinking this way. Okay. In such scenarios, if you are confused, CT scan would help you. The CT scan will demonstrate the PDA and the branch PS, because in pulmonary atresia there is a different spectrum. Some patients of pulmonary atresia will not have PAs, they will not have pulmonary arteries, they will have only MAPKAs to the lung from the aorta, they will not have native pulmonary arteries. This is the pulmonary atresia is a difficult spectrum, to diagnose, to manage. But we have to start thinking that if I can demonstrate one vessel giving rise to all structures, I am thinking truncus, otherwise pulmonary atresia. And then pulmonary atresia group, leave it to the specialist pediatric cardiologist, because they are also confused. So in our unit also, in pulmonary atresia group, we will take a surgeon along with, we have 3 pediatric cardiologists, we all will sit together and decide the plan. Single person cannot decide a plan in pulmonary atresia if the PAs are not there. If the pulmonary arteries are good size, then plan is simple, then they don't need any much workup. Repair from RV to PA, you put a conduit, things are settled down. And vertical I will show you again. Okay. Why this is I am just trying to slow it out, if you can show in frame. क्यों नहीं आ रहा? पावर पॉइंट ही आया क्या? I can't show the videos. I can't show the videos alone without. स्क्रीन पे तो मेरे वीडियो चल रहे हैं, वहाँ पीपीटी चल रहा है. Okay, 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 maybe yes. I have some other videos to answer this question, that's why. दिख नहीं रहा मुझे. हाँ, okay. Now it's not going out of the screen. I have stopped this presentation. Video. Yes. स्क्रीन शेयर करना है मुझे तो. एक बार देखो जरा. जस्ट देखो एक बार आके. एक बार देखो जरा. So if this suprasternal view is made, I will wait for the things till then. So if you have a suprasternal view, you have a vertical PD like this, and then there are PS, pulmonary arteries. Okay. So this PDA is what color? Cursor is here, no? Like this suprasternal view, we all aware of this. What color this would be? Because coming from aorta to PA. So this color is? That is the point. That's why you are not, because you are accustomed to the red flow. Skin आएगा? अच्छा कुछ गड़बड़ है ओके ओके ठीक है हाँ so now you focus on this video and see, difficult to make it still but somewhere here is the PDA see this focus on this point okay are you able to appreciate yes so that's how the image is seen permanent atresia patient cannot survive without PD or MAPKA. Either PD has to be there. If PD is not there, you are talking about collaterals from aorta because pulmonary artery flow has to come from somewhere. You understood? Yes. So either if I am not seeing a PDA in pulmonary atresia group, then CT scan will show some collaterals from this standing. Echo will not show collaterals. Difficult. Sometimes we assume and we try to show on the echo, but my idea is collateral has to be seen by the CT scan. So in pulmonary atresia, the PD is always vertical. Always means 99% times vertical, if not always. And this is the other group. Okay. स्क्रीन आपका क्यों मूव करता है again yeah okay so that's what we are showing on the PPT that there is a vertical PDA. Now we'll go again. So again I have covered truncus and pulmonary atresia. Difficult to differentiate with each other unless you are expert, but at least I am assuming that you will be able to make it DD that either this is truncus or pulmonary atresia, if not sure. Then third is aortic atresia, easy to identify because aortic atresia means LV is small. So third structure, single semilunar valve structure is aortic atresia. Most of the times, 99.9% times LV is small. So I'm not worried about this diagnosis. We all will make this diagnosis, and mostly associated with small LV or arch associated. Basically shows complex type of structures. Now when you have two semilunar valves, I am confused with these structures. When I am talking about outflow anomalies, I am confused with two structures: TGA, AP window, DORV, hemitruncus and double aortic arch. So again, now we talk about next part. TGA, I think we all understand two parallel gate vessels not crossing each other. We understand the crossing, we all understand the crossing. Aorta has to cross this, P has to come this, that is the crossing of vessels. So there are two videos, which one is TGA, which one is normal? Short axis? It will move mostly, yes. I don't know why it doesn't move nowadays. This one? Yes. So short axis view, you can all appreciate, I think. The aortic valve is anterior, PA is posterior, and this is the normal end. Because aorta and PA is bifurcating here. Here you will not see bifurcation, aorta and PA. So sometimes you see a bifurcation posteriorly, depending on modification of the views. See this now. Yes, two circles basically, and you can make them. Aorta is very anterior, and the posterior vessel is dividing. Here, anterior vessel is dividing. So normally anterior vessels will divide, that is PA. If the posterior vessel is dividing into two parts, that is TGA. This one, like this. Okay, this is the PA, this is the aorta. Here you have PA anterior, here aorta is anterior, posterior vessel is dividing. Now next view, long axis view. This is a long axis view. See this vessel? Yes. Dividing, and the other vessel not dividing. But if I say this is aorta and PA coming from aorta, can be or not can be? So if I suppose I say no, this is PA, RPA from aorta, and this is normal aorta, normal PA. Is it possible? There is one clue which says no, this is not there. Semilunar valves in both, there will be two semilunar valves. I told you single semilunar valve disease is only three: truncus, pulmonary atresia, and atresia. That is out now. We are seeing two semilunar valves. That is not in my mind now. What I am thinking is this is TGA or RPA from aorta, and I am not talking about TOF here most likely. There are 2 DD only here, either TGA or one branch of PA coming from the aorta. But when you have a PA branch coming from aorta, the vessels will be normally related. The vessel will be normally related. The branch P is arising from aorta, the valves are normally placed. If you are seeing 2 vessels together, what is this? TJ. Because normal is like this. Even if the PA comes, you will not see the other valve. Understood this point? So, run this view now, normal view, this is normal echo. That is why I made this along with normal. See this now. Okay. So, even if the PA is coming from aorta, one PA, branch PA, even then you will not see the other semilunar valve. When you are seeing 2 semilunar valves parallel to each other, that means this is TGA or DORV. TGA or DORV. When there is no VSD, DORV is not possible, out of question. हाँ sir, it's not a small presentation only. We'll come to this point. Go slow, absorb this. It's a lot of knowledge in this slide. That's why I'm going very slow. Till you have to go with me with the flow. Otherwise, you will lose a lot of things here. So, I have seen these complications, and in my mind, over the years, I have been confused with this. That's why I have come with this presentation. You will not find this presentation in any other forum. You will not find this. This is my over the years I have made this presentation and modified this. So this is my own experience. I have learned from my mistakes. I made this diagnosis of AP window, TGA, and PA from aorta. I have been confused with these findings. I have tried to find the answers. That's why I am giving today answers. Screen बड़ा करो. Screen बड़ा करना है. छोटा हो गया. So now this is easy. For me this is easy, but again let me come to this point. If you see this window, this image, I say no, this is aorta coming rise to PA. Aorta giving rise to PA. Or truncus, one vessel giving rise to PA. Some understood? So this is aorta and this is giving rise to PA. Truncus. But then you have another semilunar valve. So point here is 2 valves. 2 valves means truncus is out. So if you have defined, first I have defined, no, I have 2 semilunar valves. I am not talking about truncus. I am not getting confused with truncus. So I have decided this is 2 wavy valves. So I am not talking about truncus. That is first thing in my mind. I am dealing with single valve or 2 wavy valves. So 2 wavy valves means AP window. This is also an AP window, but I have already decided that I have 2 wavy valves. So DORV versus TOF, the DORV's problem is multiple variations. Means even I have not seen all the variations of DORV. It's not possible in a lifetime to see all the variations of DORV. There are around 65-70 variations of DORV, but you need not to go to all the details of DORV presentations. What is most important thing is discontinuity. Otherwise you can have DORV with PS, DORV without PS, DORV with transposition, without transposition. So there are multiple factors. Yeah, this is the video. This thing we showed in the morning. This is what? Overriding aorta. But I am happy no one said TOF today. I am happy today. Because there is no PS we have documented till now. So it may be I have illustrated VSD also. But in the large VSD with overriding aorta, and here you see, this, focus on this point, aortomitral continuity. I am trying to see the aortomitral continuity. Here, aorto, and here there is a tissue. You can see a tissue here. This aorta stops here and mitral starts here. The tissue here. So that defines aortomitral discontinuity. And you can override override also into picture, because how does it matter? If the override is slightly higher than 50%, how does it matter to you and to a surgeon? Doesn't matter actually, practically. When the override is too high, that is almost going to the RV, then there are surgical implications. So even if you mislabel,
Can you play this clip?
yeah, okay. So even if you mislabel DORV versus TOF, it doesn't matter much actually. But you should be see this. So, issue a tissue, focus on the tissue here, see this. Yes? So, the tissue you have to focus on the tissue here, this one. Yes. This is sad that you should have 4 mm or 5 mm tissue to call it DURV. But you can, if you start differentiating, it's very close. See, there is no difference. This is no, even 1 mm tissue is not there. Even 1 mm tissue is not there in the TOF patient. DURV. Why does this happen? If I say why not override only can be used as a DURV criteria? Because subjective. You can say it's 50%, I will say 60%. So, if it's 70% override, I will say no, it's 70, you say 50. So, override percentage wise has been taken off, but there is also a criteria. It's not that it's absolutely no, but there are subjective variations. Here also, I think this is more objective, that's why this has been accepted. Now, suppose why when the override is significant, when the override is significant, you can follow this chart, the aorta will go towards RV more, then the tissue will come here. How will the aorta will go there? By the some tissue. So, when the significant override is there, that means tissue has to be there, and that's all is called discontinuity by definition. Yes, but that's what I said. If it's 55%, suppose, how would you say 55 or 50? How do you calculate in this schedule? Is it 50 or 55? No, it will not. It will not. That's what I am saying. It will not matter, but it will matter if the override is significant. If it's 90% override, you can assume if override 90%, what does it mean? No, but surgical. You ask me, question is what is the surgical implication? That theoretical part is over now. Suppose override is 90%. Whole of the aorta is coming from RV. What is surgery here? In this patient, what is surgery? You collect this patient, this VSD like this, from this edge to this edge, and that so that LV goes to the aorta. If the override is 90%, how will you correct? So, this edge to this edge, and then where is the RV? RV will be compromised. That is the point of saying DURVs.
Correct way to demonstrate overriding, percentage of overriding. What is the correct way?
No, this is subjective. No, this is subjective. Subjective. No, that's why this idea is gone.
Sir, in this example you gave, so what would be the management like treatment, surgical treatment?
90% of override.
Yeah.
So there are different philosophies. I would do switch. What I would do is aorta will come here, switch, and PA will be put by conduit. So you sacrifice the pulmonary artery, bring the aorta to the LV, switch. Similar to arterial switch operation. Then there are things beyond this also. Suppose you say there is a PS also. Then what will happen to the pulmonary wall? You put a conduit. So there are different surgical implications, and beyond this also are there actually. There are multiple steps beyond this. The complete list of DURV is not possible.
So to check the overriding, this is the only view, or there are?
No, this is the best view. This is the only view. This is the only view. Yeah, there is no other view. All other views are not true. Not true. They have a lot of artifacts. This is the only view. There is no doubt about this. No, because in lot of views, even small VSD, you will see override of aorta. Even as plain VSD, you will see PM VSD. You will see override of aorta without any override in 4-chamber or 5-chamber views. That you can't comment. What is the problem in this view? I am not able to understand. It's the easiest view people do. You all do this view only, I think. You don't do anything else. You do only this view. I think short axis and long axis. I saw all our adult cardiologists do short axis and long axis views only. So now we come from this spectrum to the one of the PAs coming from aorta. That is called hemitruncus. Nowadays not being used. I have used it to say that not to repeat the PA from the aorta. So this is the 2-month-old child. You have cough and respiratory distress. This patient, see the flow here. Now yesterday we were talking about high flow versus low flow. Now here, this patient I thought lung collapse, lung disease, child 2 months old. I thought some pneumonia, and let me wait. But after 3-4 days also, child did not have much fever, but this shadow persisting. Then patient was sent to us for evaluation. And see this, now this X-ray is after 4 days, which thought that maybe a differential flow, left lung is hyper and right lung is less flow, maybe. Now see this vessel, the short axis. So LV, RV, and you see this vessel now again. I will go to the first thing is I told you two valves. Yes. So one valve on the left side and one valve on the right side. You have to document. But see the left vessel is dividing. See this? The vessel from the left side LV is dividing, and right side vessel is crossing also. I want to go to the videos, but somehow doesn't run after one run. So the vessel from the left is dividing, and the right vessel now will come.
And here very important thing, like it is appearing like TJ.
TJ, yeah, that's what we were discussing since.
We were discussing
Yes.
this issue. But acyanotic,
Acyanotic.
CHF, pH, hyperkinetic, and this cycle.
And see this
When
this
carrying
vessel.
acyanotic, you have to think, because we have seen these patients coming as TJ, and even went to OT with diagnosis of TJ.
So when we started, we said 2 seminal walls first. So the other possibilities are out. Now one vessel is dividing, left side, right vessel is, but they are crossing. They are crossing. See this left vessel goes left and the right vessel goes right. You understood? If you can demonstrate crossing, what is ruled out? TJ. So now see the long axis view. Again, this one also I showed you earlier. One vessel dividing into 2, but in TJ what you see here, long axis? Parallel vessels. You will always see other vessel. That is out. That is not there. So see this vessel now, I have to go anterior to show the PA, aorta. So that means the vessels are crossing to each other because they are normally related. It's only a branch PA issue. Then this view. So aorta coming from coronary is giving rise to coronary coming from the aorta and the other vessel. So we have ruled out TG in this view. Okay, so it's a continuation from the subcostal. But keep all this diagnosis which we listed in the beginning to keep the diagnosis on. Let's go. In the short axis you can't see the branching of aorta. No? The branching will be seen from the suprasternal view. So
The right atrial appendage. Yeah. So this is right atrial appendage. So parasternal short axis view in pediatric, it's very like this is most anterior structure. Rough, very rough, trabeculated, broad. This is right atrial appendage, anterior to aorta. So what thing when you know it is here, so you
Yeah.
find this structure.
So yes, see this very good scene actually. मैंने भी notice नहीं किया था इस view में, but it's very good actually. So again, I saw 2 vessels. The PA is on the left side. I am
Twice I have seen thrombus in this right atrial appendage here, especially adult, bad heart, right side especially. So you can find it.
and now see the aorta is giving rise to right pulmonary artery, and the MPA continues the left pulmonary artery. Sometimes you will find that something is there. So that's a misconception. Because since the beginning we are seeing this. Now color, see this. Now you are more sure. The RPA is coming from aorta and the MPA continues the LPA. But why I am calling this MPA? We have decided till now. How? You know the concept. Now I can't go back to the subcostal view. Again I am deciding the crossing is happened. I have shown the 2 avas, they are not parallel. So what is this? This has to be PA then anterior. Because we have demonstrated again this is not a TJ. In all views we have demonstrated this is not TJ, including short axis view. Okay, the TJ vessel mostly aorta has to be on the left side. So this is the 2D view. Some people now head looks like confluence, but this is not a confluence. When you divide this, the aorta I have demonstrated in the color view also. This PA is coming from the aorta and MPA continues as LPA. And then most important point, they are acyanotic. So again, RPA from aorta and MPA continues LPA. Right lung is hypertensive because, and left lung is volume overloaded because of PDA. This one you can skip. So again, revising the structures, this is TOF, this is high flow cyanotic heart disease, then TGA, maybe TGA with VSD here, maybe truncus here, and this is differential flow. Yeah. So a relationship of gate versus highly variable, and first step is one valve versus two valves, semilunar valve I am talking. Crossing of vessels should be documented in all exams. Tilting in different views will yield diagnosis. Tilt the probe, antero-posterior orientation, to see the orientation.
Actually, always we need to imagine we are working in 2 dimension, but 3D picture has to be in our mind. Whatever the movement is going on, we need to imagine how it is structured in 3 dimension. And slowly we develop this. It's important to, like, now online everything is available, that cross section of the heart, MRI. So you just can have that imagination of the heart, how it is with normal related, abnormally related. So always you are working in 2D, but mind should read in 3 dimensions. That should be the approach towards the structure, any structure issue.
So crossing of great vessels is best seen in which view?
So subcostal also, 4 chamber, long axis also, you can tilt the probe antero-posterior. Yesterday we showed posterior tilt and anterior tilt.
Like short
We'll show in the
axis you
short
are
child
seeing
also.
Normally, that is crossing.
You can see the live demo
Long
also.
axis, so aorta, then PA crossing each other. So you are seeing 2 different planes, and you are seeing 2 vessels
गोदी में लेके बैठे
either running parallelly or crossing.
गोदी में लेके बैठेगा आप, शूज आराम से निकाल दो और उससे बात कर लो, थोड़ा ऐसे बात कर लो, तब तक ऑन कर लेते हैं, तब तक रेडी कर लेते हैं. गोदी में लेके बैठ जाइए आप, आ जाओ. क्या नाम है आपका? बोलती नहीं है, क्यों? कितना एज हो गया?
2.5 है इसका.
2.5 साल का बच्चा बोलता नहीं है? क्या क्या बोलती है? कुछ तो बोलती होगी.
बस पप्पा
बस कब से बोलना शुरू किया है?
को 1-1.5 महीना हुआ है, चेक कराया.
चेक कराया था? कान चेक कराया है?
सब कुछ है ओके.
कान भी ठीक, कान चेक हुआ है?
हाँ जी.
किया है? किसने?
क्या नहीं कराया, डॉक्टर साहब ने वैसे करा था. बहुत
हे-
समझते
नहीं
हैं सब.
नहीं, हेयरिंग का टेस्ट
करो आई लाओ. एक कॉपी दे दो.
कॉपी दे दो जरा एक. इसको एक कॉपी दे दो, पढ़ने का शौक है इसको.
ये लो आई करो उसमें आई करो, आई लिखवा लो. आई करो आई. हाँ
अच्छा, ये देखो वीडियो आएगा इसमें.
इसको पैंट खोलना पड़ेगा.
खोलो.
ये लो खोल दे दो. ये लो आई करो अब आई करो. आई लिखो आई लिखो आई लिखो आई.
कोई बात नहीं, बात करो. टॉफी खाना तो खा सकती है. कहाँ है टॉफी? चॉकलेट खा लो, खोलो.
ये लो टॉफी ये लो. लकड़ी का काठी लगा दो,
लकड़ी का काठी लगा दें? ओके।
ये थोड़ा वो दे दे। हाँ
कुछ नहीं कर रहे, आपको टॉफ़ी तो खानी है आपको, आपने हेलो भी किया था अभी तो, टॉफ़ी खानी है आपको, टॉफ़ी खा लो।
फाइबर वाली ये लो, ये लो। अच्छा
गुस्सा है, गुस्सा है, गुस्सा है,
ये लो, ये लो।
गुस्सा है, नहीं, ये नहीं कराएगी।
ये लो, आई करो, फिर आई करो, आई कर लो, चलो बस ये आई करो, आई करो।
लिखने का शौक है इसको, शी विल बिकम पिलाटी कलर्स।
चलो लेट जाओ।
ऐसे बैठ के करेंगे, बैठ के करेंगे, बैठ के करेंगे,
करो करो, आई करो।
चलने दो, बैठ के करेंगे, थोड़ा कपड़े ऊपर का हल्के से बस करने दो। ओके
चलो आई करो, आप आई करो।
सुना बेटा, डेमोस्ट्रेट करना है तो आ जाओ, आ जाओ, थोड़ा शांत करेंगे, आ जाओ, टॉफ़ी खिला लो इसको, बिस्कुट भी खिला लो, थोड़ा बता दे कैसे करना है, बताएंगे आपको। आप आ जाओ, ये ले जाइए आप, ये ले जाओ, ये कपड़ा पकड़ ले जाइए, इनको थोड़ा दोबारा बुलाओ, कुछ खिला पिला के थोड़ा शांत करके बुलाओ।
हम एक टॉप।
हाँ अपना 10-15 मिनट ट्राई करो कुछ खिलाने पिलाने का, सुलाने का।
लेकिन अब पिछली बार भी हुआ था इसका, तो ये चुप नहीं होती है।
हम दवाई देके सुलाते हैं, आ जाओ,
एक
मेडिसिन
ये
दें।
वाला स्वेटर उतार देना, है ना, अंदर उतना ठंडा नहीं है। क्योंकि कपड़े ऊपर इरिटेट हो जाते हैं।
फाइबर लगा लो ना एक मिनट।
पे इधर कनेक्ट करें।
देख लो जरा। हाँ, लगा दी फाइबर। लैपटॉप लगा लो। लैपटॉप लगा। नहीं आया। आ गया, आ गया, देख लो, आ गया, लैपटॉप आ गया।
कल तो कनेक्ट हो गया था आराम से। पर यहाँ तो इसके हिसाब से कनेक्ट हो गया है। हाँ। So I am going to discuss about ASD, basic anatomy. And whenever we are discussing any structural heart defect, obviously hemodynamic is important, that is clinical and examination is important. So, and because this is imaging session, so how to approach atrial septal defect, different type of ASDs is I am going to discuss, and you can stop me and ask question, that is like make it interactive. Okay, for otherwise it become a monotonous talk with carry no meaning obviously. Okay. Otherwise, slides everywhere it is, theoretically everywhere it is available. Sometimes you need to close even 5 millimeters, sometimes you not. So when we need to intervene a small ASD, that is also important. Like tomorrow we are going to have a one ASD, he's 70-year-old, 70. First time diagnosed to have ASD, around 15 millimeter, and elderly issues of ASDs are different. So plan is for cardiac care to will of long case, though ASD is only 15 millimeter. So closing a ASD in grown up, you need to be very careful. Otherwise, it just complicate the situation, and patient will end up in pulmonary edema.
There was a case of around 14-15 mm, and when in this stage
So elective time of closure is 2 to 4 year of age. SSC is almost there. That is the best time to close, and we have all reversal of right heart with if we close that on time. Obviously ruling out other issues, and device or surgical depend on the anatomy.
RARP is not that electric right now.
12 millimeter should be
14 mm.
14 mm ASD RAR will not dilated ऐसा नहीं होगा. 14 millimeter is a big defect for 12 kg child. Right. So either we are like when we measure on color, okay, it overestimate your size. Plus sometimes like one ASD is small, there is one ASD and then small additional ASD. And when you put color, you will measure everything and you will find a bigger size. So most like 14 millimeter is a quite big size ASD for this child. More than 1 millimeter per kg size of ASD is there. So RARP nahi dilated ho, it should not. If it is not, you are sure that right heart is not dilated, it means we are something either overestimating or underestimating.
Fiber, like if we do, we need to do a device closure from the percutaneous route.
Yes.
And the size of the ASD doesn't increase with age.
Size of ASD increase if we suppose natural history of ASD. Okay, natural history of ASD, one is size wise. If it is below 4-5 millimeter, it closes its own. If it is more than 8 millimeter, we are talking about the fossa willis ASD only, secondum ASD. Chances are very unlikely, less than 10 millimeter. In between, 50-60% may become smaller and same remain. The increase in size happen. It may remain same. Then, because with body size, body surface area, if it is not increasing, you will comparatively see it is getting smaller. Okay, because you always talk in relation to body surface area, but majority of time the size increases with age. Okay, when you close it, it is stopped there. So it doesn't increase like your device. पता चला lose ऐसा नहीं होता है. If you close it, it is stopped there. But if you don't close it, there are more chances that there is an article on natural history. It was around 8-9 years ago about the size of increase in ASD with time.
And then the device size is like from minimum to maximum how much?
One is if all rims are adequate. Okay, this scenario is less common, but imagine. So all rims are adequate. I take 2 millimeter bigger than your anatomical size of ASD. Initially, we used to do balloon occlusion test of ASD, and we used to inflate balloon across that and stretch diameter लेते थे हम लोग. Stretch diameter means ASD आपका 10 है तो आप 15 का device लगाते थे तो almost 50% extra हो जाता था device. It was quite oversizing that time. It was in like you would say 2001 to 2010 wala time mein when things were evolving. After that we stopped doing balloon occlusion test. We just go by the anatomical size. If it is 10 millimeter, I will take 12 millimeter device. If rims are deficient, then 1 or 2 millimeter extra device size. So for 10 millimeter, around 14 millimeter, if rims are deficient, any specific rim is deficient. Otherwise 2 millimeter bigger than the anatomical size.
And when the most important rim is the inferior rim?
All rims are important actually, all rims are important. Inferior means if your IVC rim is flimsy or very thin, it is difficult. And when the opposite direction limbs are, like for IVC, anterosuperior with AV rim, atrial rim, aortic rim, and the posterior inferior, if like opposite direction limbs are deficient, then it won't. Okay. In mass and कॉलर तो है बेटा, लेकिन कॉलर नहीं है ना मेरे पास. So, timing of intervention, basically, in short, I am going to talk about. So, shunt wise, we have atrial shunt, we have ventricular shunt, we have shunt at the level of great vessels, and that level of shunt, Dr. Neeraj, and yesterday we have talk about these issues. So, atrial shunt, majority are asymptomatic. Okay, the murmur is detected on routine evaluation, and you send for echocardiography, you find there is lesion in the heart. Only 5 to 10% present with chest infection or CHF or pulmonary PA pressures are more than usual, and those are the kids you need to intervene early. Okay, but in general, ASDs are very silent sort of lesion. When you have early presentation, preterm babies have very rapid fall in the pulmonary vascular resistance. That's why you need to, they are more symptomatic, so you need to require fixing them early. Bronchopulmonary dysplasia affect many ways in the heart. Because all the adult cardiologists used to do echo for newborn also. So that is newborn a very different heart. So bronchopulmonary dysplasia lead to LV diastole dysfunction also. So whenever LVEDP is high, like in elderly or in newborn because of some other issue, your shunt will be larger. So bronchopulmonary dysplasia, preterm, anemia, hypertension or any associated heart defect lead to early failure in atrial septal defects. So ASD anatomy is important, but why their load is other than more than usual, or like if it is not 15 millimeter ASD is not RARV dilated, means it is not fitting into the anatomical size of ASD. So both way you need to look on the heart and plus clinical picture plus chest X-ray plus rhythm, everything you need to look to explain your anatomy with the hemodynamic load on the heart. And this is the natural history you were asking. So small ASD is close, more than 8, hardly less than 10%, in between this way or that way. So 4 millimeter ASD, 4, 5 millimeter, yesterday you were asking whether to label as PF or ASD, whatever it is. It's not bothering us, but yes, we need to understand the definition. Okay? So if flap is there, it is PFO. If there is T sign, so it is atrial septal defect. But you can write both things, nobody is going to challenge you on that particular situation. The ideal age of closure is 2 to 4 years, means before school age, preschool situation. We need to correct the structural defect if they are significant, and obviously your PA pressure has to be acceptable. If older patients, the studies have shown that below 24 years survival is comparable to control. More than 25 years, they are definitely better, but less than control. So graph shows that. More than 60 years, there are studies whether ASD to be closed or not. Again, it depends on the hemodynamic. If PA pressure are acceptable, you offer closure of the atrial septal defect. But the decision should be taken very carefully. Filling pressures are very important. One of the patient I did CAT sir abhi last month for ASD, EDPs are 30, left and right. And ठीक है, sizable ASD है, shunt is there significant, but what will you do with these EDPs? So fixing ASD is not the answer in that patient. He is 65, 68 years old, so kept on ACE inhibitor, I send on diuretic and after load reducing drug, and we'll see, we do recath and then we'll decide what to be done. So these are very difficult situations. So anatomically you have ASD, shunt is also there, but LV EDP 30 won't tolerate closure of atrial septal defect. You will just, the patient will get complicated on table only. So for fossa Willis ASD, it is mainly device, while rest of the ASD, it is a surgical, or a fossa Willis with deficient rims, with large defect, you also go for the, or any associated other surgical issue, obviously you go for surgery only. You can't do 2 intervention ASD, to main karungi VSD, aap operate kar dena. This is not the, like, large definition wise, if you ask me, large ASD is equal to, if ASD size is equal to mitral annulus. So this is definition wise. Okay, then body weight, we can't put a device more than, usual saying is 1.5 time of body weight you can use device. So suppose 10 millimeter, suppose 10 kilo bachcha hai, I can use 15 millimeter tak device. But again, rim is important, you can't compromise on other structures. Okay, people have used even 20 millimeters, 2 times of weight device. But everything you need to look in totality. So size is different for age wise. Anatomical definition wise, this is the size of large ASD if it is equal to mitral annulus size, but add everything.
Sir, in case of adult persons, this is not related with the weight.
Yes, it is absolute. So more than 30 millimeter take it is large when we are talking about our studies large ASD in adult population. So 30 millimeter we take as a number. But rims are important.
Not important. Suppose there is adult is 20 millimeter ASD or
Yeah.
30. Does it make a difference? Does it make a difference really? No. Both have to be close. No? Yeah. So it doesn't matter really. Actually.
Yeah.
The device size is
Device size available.
Device size is like the implants is there for long. Now we have LifeTech and they have, so initial device size we used to have 4 to 40 millimeter. Now we have more than 40 millimeter also. So if you ask me what largest size ASD I have closed, 38 millimeter I have closed. Okay. People have done more than 40 also with the availability of larger device with LifeTech, that is a Chinese company. But in general, okay, 30 ke upar we need to be careful. Okay, we need to be careful because that is a large, coming into the definition of large. So when we say large, means rims issue has started happening. Okay, so careful, we need to be very careful. Just fixing a device is not the answer. You will fix. आपको 35 में 40 नहीं तो 44 fix कर दोगे. But you should not compromise on the structures. Okay.
Surgical closure is very simple.
Very safe.
Simple.
Very safe.
So don't go to that boundary where you should not close that.
Yeah. So when I talk to family for ASD intervention, I tell them clearly, this has proven as a safe measure to close the atrial septal defect with a good long-term outcome. This thing is also, and choice is, today's scenario is device for this particular size of atrial septal defect, but you can choose safely. There is no negative vibe when you go for the surgical, definitely not from me. So long-term results are excellent if we take all precaution and go according to protocols. And this is the ASD device, so there is nothing new to talk about that. Then coming to the post-tricuspid shunt, VSD, PD, AP window, Dr. Neeraj has shown all the things. So presentation is basically symptomatic by the end of the first month of life with fall in the pulmonary vascular resistance, child start tachypnea, mother says that child is not feeding well, so they shift to bottle feed. So this is the history most commonly you get. Mother ko feed hi nahi hota, bachcha rota rehta hai, that's why we are, but the situation is different. It is because he is not able to suck, and taking mother feed directly is a very heavy exercise, and bottle feed is very easy. So that's why they shift to bottle feed, and everybody is happy, weight gain start ho jata hai, baby comfortable ho jata hai, rona band ho jata hai. Okay, so that comfort comes, but it is the thing is he is having significant intracardial defect. And if something like that happens, we need to go for pediatrician, and they, if needed, they counsel the family and advise for the issues in the management of VSD, as you were asking, is size of defect, site of defect, number of defect, pulmonary artery pressure, pulmonary vascular resistance, and natural history, what we are expecting. So everything is important in these patients to decide about when to intervene, how to intervene, or nothing to be done. Okay, so natural history wise, muscular VSD almost 80-90% get small or close. Okay, so a safe, even larger muscular VSD known to have, but you don't wait. Suppose a large muscular VSD is there, child is suffering, it may close type thing, we don't wait. If VSD load is significant, child in CHF, PA pressures are high, you need to close by 6 months of age. So irrespective of the location of the ventricular septal defect. Okay, but in general, this is the first natural history. This around 1/5 overall get small or close. Aortic regurgitation around 5 to 10%. Infective endocarditis around 5%. Infundibular PS means simple VSD going into the top physiology is around 5 to 10% of patients happen. Eisenmenger syndrome overall 5 to 25%, but when VSD is non-restrictive, chances more than 50% they go into development of the Eisenmenger syndrome. And this is the survival. Once they are diagnosed with Eisenmenger syndrome, 5 and 10 year survival is 77 and 58%. So this is something obviously is preventable but not a correctable situation for the shunt lesions. Management for non-restrictive VSD, very important is nutrition. So feeding is very important for these patients, high caloric feed. We increase, if mother feed is there, very good, we add MCT oil to that, or they are on formula feed, we increase the concentration of the milk formula we are adding. So whatever the way we try to increase to the calories. Hair lessings is important with aldactone or ACE inhibitor, okay, and closer by before 6 months of age. If they are okay with these medications, sometimes they are not stable, you may to go for surgery for 2, 2.5 or 3 months of age, especially Down syndrome, early surgery is indicated in them. When moderate size VSD means PA pressure are not systemic, less than 60% of systemic, you have time, they are apparently stable, so you have some time, 6 months to 1 year. Restrictive VSD, no MDR, basically no volume load, normal PA pressure, you just need medical follow-up. But restrictive VSD, if aortic valve is prolapsing, if there is development of AR, you go for surgical closure of the ventricular septal defect. So clinical is important, echo is important, everything is important, you need to take decision in looking at those points. AR, very carefully, Neeraj has yesterday shown that aortic valve prolapse. So aortic valve prolapse picking is very important, and that is for the perimembranous VSD. So short axis you have 3 VSDs, as yesterday we have discussed, doubly committed, most common to have aortic valve prolapse, and that start 5 to 10 year of age. But in Asian population, especially India, I have seen aortic valve prolapse under 1 year of age also, and significant prolapse. This is not uncommon for us to see aortic valve prolapse in younger. Theoretically, if you see it is 5-10 year of age, they talk, but we see differently. Obviously, we and it's same Bangladesh or India, we see it early. So always keep a watch. So doubly committed, outed, trabecular, perimembranous, all three can have aortic valve prolapse because all three are related to aorta, and keep a watch is important in these patients. It doesn't happen overnight. So all sequential echoes are important to pick up. Is start buckling and then prolapsing, then aortic regurgitation. So that way it happens. So, but we need to keep an eye over that. AV canal defect, so 3 to 6 months, like any large ventricular septal defect if it is complete. So AV canal defect, ASD, VSD or both components will be there, plus mitral regurgitation, plus minus tricuspid regurgitation. So everything is ugly in this heart. So if it is ASD only, you follow like ASD. If it is VSD only, you follow like VSD. If both are there, as per VSD. If there is regurgitation, cleft mitral valve, you will require early surgery in these patients. So 6 months, when VSD is significant, inlet it is there, before 6 months of age, we have to intervene in them. If they are stable clinically, you may miss. That happen only when VSD is small, otherwise they will be sick. And this is the most sickest group from the intracardiac shunt point of view. PDA, I think PDA we have discussed. Preterm PDA is very important. This is all you should know, because when you go to nursery, this thing bother you a lot. So preterm baby with PDA is a different disease. So one is term PDA we follow, we do device closure, we do surgical ligations. But preterm PDA, if hemodynamically significant, means there is tachypnea, tachycardia, white pulse pressure is there, they are obviously preterm. Respiratory oxygen dependency is there, ventilator dependency is there, chances of NEC there, intraventricular hemorrhage is there, pulmonary hemorrhage is there. Anything happen with these babies. If it is significant, the first thing is pharmacological closure, and majority respond to pharmacological closure. Ibuprofen very safely we give. Paracetamol also, some pediatricians say it is equally effective as endomethacin, ibuprofen, but choice is of pediatrician, whatever he is comfortable. But a trial should be given in a term baby by the medicine. One trial or second trial, if things are still persisting, you go for the surgical ligation of these PDA. Again, in selective cases, preterm PDA device closure is being done. Now we have smaller device, small miniature hardware, because the hardware is there to do that. But when to close, that is also important. Okay. Preterm PDA ligation or device closure, in long term, no significant difference when you follow medically or you do, but NICU is still definitely being affected when you intervene them according to protocol. This is just device closure. I'm not AP window. I think we have discussed. So all AP window or RPA from ascending aorta, like Neeraj just showed. So they have to. We have to intervene these patients in early. Early means 2-3 months of age. We don't wait for 6 months because they don't give us 6 months. So you diagnose them and you like why this is, you see the AP window is large. Most of the time, very small time it is a small AP window, but in general it is a, you see pulmonary artery at systole and diastole both at aortic pressure. Okay, with VSD we have only systolic hypertension. Diastole are normal. With PDA, we have systolic plus diastole, but PDA have a long length that offers some resistance towards the pulmonary artery. So sort of some protection is there, but here it is directly hit by aortic pressure. So AP window and PA from ascending aorta very early Eisenmenger or truncus arteriosus. So you do need to close them early. Okay, 2-3 months. Don't wait for 6 months or 1 year in these patients. You diagnose and go towards closure. I think now I should go for ASD talk, you know? And this valvular lesions you all read in adult, it is same. There is nothing difference in management point of view. So ASD, commonest being fossa ovalis or secundum ASD, whatever you say. Then sinus venosus. The second common is sinus venosus, then ostium primum, and rarely coronary sinus type of defect. PFO is not taken as ASD, but it is one of the interatrial complication which sometimes require intervention for that also. That's why I put it here. So the commonest defect is secundum ASD, which will show images of everything here. And the presentation, as we have discussed, is murmur most of the time, and less commonly with the features of CHF. Ostium primum ASD, because there is mitral regurgitation, they have larger shunt and they present early. Coronary sign of ASD. Coronary sinus of ASD means left SVC and root coronary sinus, and they have some desaturation. The presentation with CVA may be there. So that is totally different presentation in these patients. Usually it is situs altus levocardia or situs inversus dextrocardia. Okay. Left isomeris may have isolated atrial septal defect, but right isomeris is most of the time complex congenital heart defect is there. So this is 4-chamber for you, inverted 4-chamber. For me it is for me it is inverted, for you it is usual. So RA-RV is dilated, and this is M mode. I take M mode in all patients whatever I am dealing with. So this is as a practice with Dr. Savitri Srivastava, respected ma'am. So we always take M mode, and that show you the septal motion in relation to cardiac cycle. So with ECG you can say right heart is dilated or septal motion, it is flat septal motion. So you get many information from M modes. So dilated right heart with flat septal motion. And what we need to see is where the defect is located, what is the size, is one or multiple ASD, or there any associated anomaly like systemic vein, pulmonary vein, left AV valve or pulmonary valve, what is the hemodynamic load, and decision about intervention, whether to close or not, if to close, how it is. So these everything you need to answer by your echocardiography with the addition of the clinical including ECG and chest X-ray. So views from transthoracic point of view, subcostal view is very important when we talk from the pediatric, but in adult modified views you require, like subcostal view, coronal view, parasternal short axis modified will give you same image which you get from subcostal coronal view. So you have to replicate the image from different view to different views. So that's why it is important to look at the heart in 3 dimension. So subcostal windows are bad. Usually in obese patients windows are okay, not bad, because fat is a very good conductor of ultrasound waves. But muscular man, that time major difficulty come to look for the images. But sequentially subcostal, apical, parasternal short axis view, these are the views give us definition of the atrial septal defect plus use of other views to complete your echocardiography study. Okay, so it is not uncommon for you to have a so-called that dropout in apical 4-chamber view, and they come for ASD, referred to us for atrial septal defect. Even patient was taken to cath lab for device closure of that ASD, and there was no atrial septal defect. What you need to see is evidence of volume load, like 15 millimeter ASD in 2-year-old child, RA-RV has to be dilated. It means I am reading something else, that is important. Same way for adult. If right heart is not dilated, this is not a significant ASD, we should be closed. Okay, so drop out whatever number it says, but if volume load is not there, so definitely it is not, ASD is not the culprit. So I have to go for transesophageal echocardiography in adult patient. Like yesterday I was sharing one adult patient, ECG wise no R wave, means we on right sided leads R hai hi nahi. So there is no evidence of RV, RBB chodo, there was no evidence, very small R wave in right side. So it was LV dominant ECG with right history of CVA. So obviously I am not dealing with a ASD leading to volume load over the heart. Okay, so that is overall in information you need to get in these patients. Okay, so rims wise, how do you understand ASD rims? when we talk about the Fossa-Wallace ASD. Okay, again, imagining the heart in 3 dimension is important. So this is LA, this is RA. Okay, this is atrial septum. Here comes the aorta. Okay, here comes the IVC. Here comes, my thumb is SVC. Okay, this is posterior rim, posterior superior, posterior inferior, and this is anterior means retroaortic rim. So इसको imagine करना बहुत important है, and you need to like in 2D you always 3D, if you have, you are using it, is very good. If you don't have, that doesn't mean you are missing something. It's not that. It's how you trained your mind. That is very important. So this atrial septum in relation to these rims is very important. Okay. So this is my. So this is IVC, superior vena cava. This is the right atrial site of the atrial septum. Okay. And fast view. This is retroaortic rim. So retroaortic rim, when I put, if it is like, that's why I said we need to look at 180 degree, है ना? पूरा देखना important हो जाता है कि मैं यहाँ से यहाँ तक देखूँ. In one view it may be having deficient, but other view it is better. So I am okay to go for the device closer. Same way this is atrial rim, this is atrial rim, this is AV valve rim, SVC rim, IVC rim. So all rims you need to imagine in 3 dimension to give a complete picture, to have a complete picture, because you are the one who are going to advise whether to go for device or to go for the surgery. Okay. In general, 5 millimeter is adequate. So we take 5 millimeter. If you overdo, even with 3 millimeter, some people are able to do, but to learn 5 millimeter, if it is there, I am comfortable with the, and it has to be a strong rim, stout. It's not flimsy rim. So 5 millimeter flimsy has no meaning. And most of the time, IVC rim is flimsy. So, yeah. So this is subcostal coronal view, subcostal sagittal view, apical 4-chamber view. So what are the rims here? This one, yes, AV or mitral. This is, yeah, yes, atrial or posterior superior. So this is bicaval, IVC and SVC. And what is this structure here is? What is this? When we look at image, उसके आगे पीछे जो भी है वो भी देखना होता है. ठीक है, it has no association with ASD. But what is this? Like I said, I showed you RA appendage there. है ना? So हर जगह कुछ दिख रहा होता है आपको. So जो भी है, so this is RPA. Okay, so RPA आपका ऐसे निकल के ऐसे जाता है ना? So it goes posterior to this side, है ना? यहाँ से आके ऐसे जाता है. This is right pulmonary artery. Okay, so this is SVC, this is IVC, this is hepatic vein here. Right pulmonary vein comes like this, right upper pulmonary vein, right lower pulmonary vein goes like this. Okay, left pulmonary vein like this, left upper. So you have so many things in this view. This is, sorry? This is subcostal bicaval view. है ना? So here this is your RPA, this is SVC, and this is central atrial septal defect. Very beautiful. So it is straightforward, looks like for device closer. This is 4-chamber view again. So AV rim, atrial rim, and you can see pulmonary veins, you can see aorta related to left atrium, ventricle septum looks okay, right heart is dilated. So usual atrial septal defect with central defect. Okay. This is same thing modified, and this is complementary TE view. So again you have good IVC and SVC rim. This is inferior vena cava, central defect is there, right heart is dilated. Okay. You can see RPA here. In this patient, RPA will be here because that is T view. Same apical 4-chamber. This is at 0 level T view and apical 4-chamber. So complementary views are there. All adequate rims. This is left lower pulmonary vein. Okay. And in 4-chamber, right inferior pulmonary vein. So left inferior, right inferior pulmonary. What happened? So parasternal short axis view or 40 at 40 degree mid esophageal views we are dealing with. So you have aortic rim, which is good, and posterior inferior rim. Posterior, superior. With the, this with aorta,
Posterior inferior.
with aorta, posterior, superior.
With mitral.
With mitral posterior superior.
Uh, okay. So with aorta, posterior, inferior. Yeah. Yeah. So with mitral, posterior, superior. So this is T view at 0 and this. So AV rim, posterior, superior rim. Okay. Again posterior, inferior and aortic. Here aortic rim is a bit deficient. Absent nahi hai, but hai. So, yeah. So I will go for device closer in this patient with this rim. Okay, and here it is very good, aortic rim. This one is bad actually, है ना? So अभी तक we were seeing a good aortic rim. This is borderline. This is good. This is completely barred aorta. We have done device closure in this setting also. Touch wood. As of now, things going well. But there is very good article of 2014-15 about ASD device closure, long-term complication, erosion and all that came into that, and the mainly aortic rim deficient or oversizing of or using device in borderline rims. So where things are borderline, complication may happen. So need to be very careful in borderline situation and explain the family accordingly. So this is 3-dimensional structure, okay, showing a very central defect, no issue. So this is aorta. Okay, so again we have the rims all over adequate. There is additional defect. So next question is when to put 2 device, or should we go for 2 defect for surgery? So this is the question, because one is finance. Okay, when I am going to put 2 device, obviously cost is going to add. So that should be clear to the families. Finance is not the issue. With this type of defect, I will go for device closure. And if distance between 2 defect is more than 7 millimeter, because disc is 7 millimeter. Okay, if it is more than that, you can't cover with one device other defects. That's why you need to put another device in that situation. But again, one is that additional ASD should be large enough to close. If it is 3-4 millimeter, you are not going to add anything extra after closing this, putting a one more metal inside the heart. So the decision depends on many factors.
Can we close it with one device?
Yes, when they are very close to each other, we go by one device only.
Is there any measurement?
This is, if it is more than 7, you definitely need to put another device.
2 devices.
Yeah.
If it is less than 7, we can try.
Yes. Okay, and plus if it is very small and a small 3-4 millimeter you are leaving, it's not making any hemodynamic significance. Okay, so you can leave it if it is additional one is very small. So all defect again need not to be close. So technical modification, usual ASD device closure is you go straight forward from IVC to RA through the atrial communication to LA to one of the pulmonary vein. You take your sheet there, you take device inside that, and I think you all have witnessed ASD device closure or have done ASD device closure. But difficulty come when limbs are borderline, defect is large, then you need to be, it should be done with expertise actually, it's not a smooth case. So you need to be ready to handle the complication, means device embolization or anything. So that is the importance that this type of defect should be ideally done with a surgical backup. Okay, and ideally any patient can develop complication. To be honest, we have embolized 12 millimeter device, we have fixed 40 millimeter device. So there is nothing like this is small, it is smooth. Nothing is smooth when you are inside the heart. Okay, so precaution is very important. That 12 millimeter ASD was it was case of PS. Underwent balloon dilatation in infancy, and now she is 13-14 years of age. Because PS newborn situation, RV is borderline. Okay, and especially hypertrophy. Some issues persist with neonatal PS, critical one. So that ASD was more of bidirectional, and we put ASD device there. And because it is bidirectional, not because of PA pressure, because of diastolic issue, so RA disc is smaller than LA disc. So our choice ideally should be a PFO device. You have a larger RA disc, and we put ASD device, and it embolized after 3-4 hours of procedure. Obviously, all issues happened. It straightway went to aorta, arch of aorta. Okay, normal embolization, it goes to the right side of the heart, but because it was that fluctuation of pressure, right one, because of diastolic, means RA was intermittently getting higher than LA pressure, so it got embolized and went to aorta. So you can imagine issues happening in that scenario. So that's why all cases are difficult case. There's nothing like. We had to, that child underwent surgery. You can snare it, okay, but it was in that situation just sitting here in transit. So carotids are there. You can't play with the snare here. Safety is very important. So just surgery we taken out, and surgical close of ASD was done. But if it is in pulmonary artery, you have time, you can do. But don't waste too much of time. Nahi ho raha, it is okay. Surgeon is there to take out the device and put a stitch over the atrial septal defect. Okay, but yes, snare should be there when we go for device closure. Snare should be in our cath lab. Yes, you need to hold the hub, that knob. Okay, so smaller the snare, it fit, and you just need to retract it inside the sheath. You take one size larger sheath, which you were using, and it is difficult, but theek hai. You need to hold the nub. You don't need a bigger snare, because you can't, open device you can't take out. You have to take it inside the sheath. Okay, and a separate vascular access you need for in that situation. हाँ, नहीं, आप हार्ट के अंदर ही उसको शीथ में ले लेंगे ना. आपने नब को स्नेयर कर लिया, and you pulled it inside the sheath. Okay, and take it out. Okay, if yes. You should not play on aortic side much, because you can't compromise on aorta femoral artery. You will lose the limb. Okay, so these are the issues when floppy aneurysmal rim, floppy septum, prominent cherry malformation, multifaceted ASD, multiple defect, or large confluent defects, these may happen. So when shunt is bidirectional, so one is PH is there, but in pediatric age, more than that is tricuspid wall is smallish. In adult, like I was discussing, that adult patient, so a pediatric adult everywhere this can. Isolated RV hypoplasia is not very extreme rare situation. A patient came to us around 10 years of age with cyanosis only as Eisenmenger ASD. Okay, and it was RV was hypoplastic. So all cyanotic patient without PS are not Eisenmenger. When volume issue is there, they will also come as a cyanotic patient, because ASD is giving them that decompression stress to maintain cardiac output. Okay, so assessment of looking at all the valves is very important. We can't ignore, in general, tricuspid and mitral almost same, but tricuspid is bigger than mitral, normal. Okay, if tricuspid is smaller than mitral, you should be worried. So this is just Doppler across the ASD usual Doppler. This is color Doppler, and this is the position of the sinus venosus atrial septal defect, PA pressures, and this is the way we write our echo report for ASD. ASD, this millimeter size. If there is additional defect, you mention direction of shunt, rims are adequate or not, volume overload, PA pressure, special comment on systemic and pulmonary veins, ventricular function, systolic, diastolic, and what is my plan for closer, to close or not, to close, then possibly device closure I will mention. and discuss with family about the alternate mode of closure also. Yes, it is important because I am planning for device closure. Okay, so I can't, and PAPVC is there. So I need to, if one vein is anomalous, surgeon won't route that single vein most of the time. But we need to explain the family that that particular channel is there, it will remain like this only. If you want to have, you can have a surgical opinion that if he's going to route it, it is okay. If to close only ASD, we can do it by device closure. Systemic vein wise, again it is important. Sometimes you have interrupted IVC. Okay, if it is interrupted IVC, you can't go from straight course. You have to take other course. Okay, either I go from jugular vein, okay, or transhepatic you will go. But you need to modify your procedure. One of our patient, 10-year-old, came for ASD device closure. I saw him neonatal period with PDA and ASD, and he had neonatal sepsis and this and that, and then PDA surgical ligation was done. Obviously, ASD was not touched that time. Prolonged NICU stay. Now we were following him medically and planned for ASD device closure. And we took in cath lab. Both femoral veins were occluded. And this was, obviously IVC was patent, but I did not check for femoral vein. So ideally, when we are planning for procedure, we should have a groin Doppler. Okay. So there was no access for me. Then we did from jugular. So, and jugular is not a very routine approach to go for, because your angle is very different. For when I go from here, it's smoothly ASD device. Our mind is tuned to that angle only. When you need to modify it, you should be prepared beforehand. कि यहाँ से होगा, आपको सब कुछ imagine करना पड़ता है when you are going to cath lab. So that planning is very important. Okay. So femoral Doppler, any patient who had a previous ICU stay for some reason, you ideally should have a femoral Doppler. Ideally in all patients, because this venous anomaly can happen with anyone. Okay. So preparation is very important. So in that patient, we were not prepared for that. Obviously, it took extra time. We were puncturing, wire was not going. We took injection from both sides. So it was completely collateral formation. Then we went from jugular vein. So venous is very important. Okay. For surgical point of view, left SVC if it is there. So we need to inform the surgeon beforehand, because accordingly he need to, when patient is going on pump, so he need to cannulate left SVC also. Jugular, we use Mullin sheet for device closure, and it is a softer sheet, so it takes that angle. And but when I go from jugular, my device is pointing towards mitral valve, सीधा, है ना? So it's a bit difficult because orientation थोड़ा different हो जाता है उसके लिए.
How can you reach the pulmonary vein from the?
Yeah, in that case, my wire was in LV.
Yeah.
Okay, sheet was in LV, and I withdraw and then release the device in LA, one disc, and then in RA. Because from there, if I enter the pulmonary, it has to take a U-turn. Yes. I went to LV. Yeah. Through jugular vein, I did only one patient, and I went to LV. But very careful to look at the mitral valve. ना आपको एक extra काम एक तरह से बढ़ जाता है. ठीक है, mitral valve you have to look always, but here you are working there only. Yeah. Like interrupted IVC, there you have to take all the long course. So pediatric, the sheet is of that length you can manage, but in adult you don't have that length, so you have to have jugular only. Ostium primum ASD you all know, common AV valve. Okay, ASD in lower part of septum. What is this? Okay, it is written above. है ना? So this is cleft. Common AV valve. AV valve at common junction. Okay. So cleft is seen here. This is gooseneck deformity. Gooseneck deformity is a systole or diastole? Diastole. Okay. Look, when mitral AV valve is opening, then you are having this shape. This is isolated cleft, we should check, है ना? So this is the cleft in anterior mitral leaflet. The jet is directing here. With commissural's cleft, like in rheumatic, you see jet coming from this area, or central cleft because of some valve prolapse or something, central jet you will see, and here it is clearly from the anterior. No, this is, you can see, it is coming from this cleft. Yeah. Here my cleft is. This is again ostium primum ASD with dilated, but if you look at the jet, so with ostium primum ASD, yes, partial AV canal, there is ventricle, this is intact, valves at same level, okay, and you look at the jet, so LV jet is going to RA, RV going to LA, sometime middle jet, so all mixing happen in these patients. That's why assessment of PA pressure becomes so difficult, because jets are mixing with each other. If any doubt, go for better to document by cardiac catheterization, okay, because exactly catching the TR jet or right AV valve jet is difficult with ostium primum ASD. If RV to LA jet is significant, he will have some desaturation. Like in common atrium, you have some desaturation, saturation around 90, 92. So for partial AV, ostium primum time of ASD, my report will be partial AV canal defect, ostium primum ASD, with direction of shunt, with AV regurgitation left, right, and you need to define cleft, volume overload, PA pressure, left SVC quite commonly associated, and left SVC is commonly unroofed in these patients. So 4-chamber view, posterior view showing the coronary sinus dilated is being not there. It's not uncommon to have a coronary sinus type of ASD in these patients, means left SVC is directly connecting to left atrium. Okay, so very careful we have to be. You are explaining some desaturation by RV to LA jet, but it could be additional left SVC to LA. So left SVC को ढूंढना बहुत ज़रूरी होता है. Left SVC का association is higher with left-sided obstructive lesion, especially coarctation of aorta. So in fetal echo, when we see left SVC, we keep a question mark about that. I need to follow this patient for coarctation of aorta. Okay, I don't ignore. In general, it is of no significance, but when we see in isolation in fetal echo, we put a mark that I need to follow this for aortic arch. Here, this is quite possibly unroofed. So better to know, because it's a surgical case again, and surgeon will shout in OT. You have missed left SVC to LA.
That should be first thought because of the direct coronary sinus in this setting.
Yes.
And then we have to go to suprasternal.
Yes, but when it is unroofed, you won't see dilated coronary sinus. So that is the problem. If it is dilated, it is easy. You are seeing dilated means it is left SVC coming to that and you follow. But when it is unroofed, then just always do all views. Okay, so look, find SVC, whether here it is, there is sign of dilated as coronary sinus is there or not. You have to have a look over the innominate vein and any channel descending from that, and plus checking the saturation.
Then that question should be sent to you.
From suprasternal view, yesterday we show it. You make a short axis view. Okay, long axis you are profiling arch in long axis. So short axis view, the uppermost thing is innominate vein, then aorta in short axis, transverse arch, then right pulmonary artery in long axis, then left atrium receiving all four pulmonary veins. So the crab view. So all four structures. If innominate vein is not here, it means you are having left SVC. Okay. Sometimes you have left SVC with innominate vein also. Okay, so variation is there. Better to check this end of innominate vein also, that something is not coming from that. Okay. Then contrast echo. Any doubt? Do contrast echo. So here dilated right heart and this SVC type sinus venosus ASD you have seen yesterday. I am going to show you IVC type sinus venosus ASD. This is T, you all know that. So IVC type sinus venosus ASD, we have this large series of publication about IVC type of sinus venosus ASD. This is one of the less common type of sinus venosus defect. Common is SVC type. So here, like in SVC type, SVC is overriding the defect. Here IVC is overriding that defect. And when IVC is overriding that defect, with IVC it is right lower pulmonary vein. So right lower pulmonary vein will be enormously draining. Okay, and in 4-chamber, how it is seen, like IVC type of ASD, you can easily pick up from 4-chamber view. So the defect is here at the top, because in 4-chamber IVC is there. Okay, so wahi place hai, that is defective. So 4-chamber view, you will find the uppermost part of the atrial septum is missing. And when you go to the different views, like this is so this is the plane of inferior vena cava, and you can see the if you do contrast echo from femoral vein, a jet will direct towards left atrium. In general, it is left to right shunt, but because of overriding, you may get filling of left atrium. Okay, you can see this is the left to right shunt, and IVC is sort of facing towards left atrium. And here, right lower pulmonary vein, you need to define from different views whether it is. This is the defect. This is right lower pulmonary vein, and it is to right atrium. These are the modified views to defining the atrial IVC type of atrial septal defect. So for adult in 4-chamber, to say sinus venosus, the first thing is fossa valis should be intact. Okay, and you know where the fossa is defect. You may have 2 defects, but isolated sinus venosus defect, fossa valis area has to be intact. Okay, that is first thing. 4-chamber, you don't see SVC type of defect. You just see dilated RARV. Okay, but in 4-chamber, you see IVC type of sinus venosus defect. So at the top pay, you will find a defect. And for SVC type, when you go anteriorly, you open aorta, you will find the defect. That is from apical 4-chamber view for adult patients. And very important thing is dilated right heart, seeing those defects, either fossa valis or it is PAPVC. So you need to have explanation for that. Okay.
Will you highlight to some extent on the detection of PAPVC in association with sinus venosus?
Yes, like this view, this is subcostal view. Okay, subcostal coronal view in posterior plane, because I am seeing hepatic vein, I am seeing IVC. Okay, so this is the most posterior plane, this is my IVC, and pulmonary vein goes like this. Okay, and because this area is defective, it is draining here. So site is normal, but because of deficiency in that area, it is draining into right atrium. Same way with the superior vena cava type of defect. Okay, because it is unroofing of the pulmonary vein, so draining abnormally. So what surgeon has to just roof it, sort of that area.
Have you got comparable TE views?
Yes, I think I have. So this is, okay. In very posterior plane, this is IVC. Okay, bicaval modified view hai, 4-chamber modified view hai, and at the topmost area there is defect. So this is 4-chamber view. This is tricuspid mitral valve. This is atrial septum. This is fossa valis area, which is intact, and the defect.
Ma'am, in case of transversive view, apical 4-chamber, normal apical 4-chamber, we can't see any gap. In case of sinus venosus type A, the superior vena cava.
Yes, you don't see.
You don't see any gap in the superior part, but in case of inferior vena cava, there is a gap.
Yes,
in
yes.
the 4-chamber.
Yes, at the
Without tilting.
Just usual 4-chamber view will show that top part is defective.
Defective in inferior.
In inferior vena cava.
But superior SVC type, it is.
You won't see.
Tilting is needed.
Yes, you won't see any defect in 4-chamber view. Okay.
When it's clearly
Yes, subcostal view, or like in pediatric we can see from 5-chamber view, because it is aorta and SVC at same plane, so you will see the defect there. Okay. In pediatric, bicaval. Even in adult, bicaval view tell you that the defect is there, and obviously then you go for transesophageal. Yes, yes. This is sinus venosus defect, inferior vena cava type or superior vena cava type. Okay, superior, when it is related to SVC, it is SVC type. When it is related to IVC, it is IVC type. So vena cava defect it is. With SVC type, most of the time have association with PAPVD. IVC, not always. Our 40% of patients had PAPVD, not all. Superior, almost always. Okay, so this is right lower pulmonary vein and draining into right atrium. This is TE picture, modified. This is clinical ESD with the mild desaturation. Okay, so contrast echo I am going to show you. There was a picture with the contrast echo. So you will see a contrast coming here. Okay, so they come as sort of borderline saturation because only one SVC, so 2/3 of venous return is going normal, only 1/3 is enough.
Suspect whether this patient has caused sinus ASD or not.
One is ASD patient if there is some desaturation. Then you have to find either systemic venous anomaly, because ASD is clearly red, it is left to right. So it is not the cause of cyanosis, ASD as such. Okay, but patient is having 90% saturation. So I have to go for contrast echo. If I can profile SVC, very happy, I can profile. If you have a doubt, better to go for contrast echocardiography, saline contrast in OPD only. Just put a vein in left arm. You will rule out, one is if it left SVC is coming to LA, so-called unroofed coronary sinus or coronary sinus, you will just see direct contrast into left heart. If it is because of pulmonary malformation outside the heart, so it's after a gap it will come to left heart. That will give you the information. So any borderline saturation, just use contrast echo frequently. Okay. No. For what? For pulmonary fistula? 6 is too long. 3rd, 4th beat. If fistulas are large ना, तो वो इनफैक्ट सेकेंड बीट में ही आ जाते हैं. ओके, बट इंट्राकार्डियक नहीं आ रहा, ये आपको दिख जाता है ना. सो वो इट्स कमिंग फ्रॉम पल्मोनरी वेन्स, नॉट थ्रू एएसडी और वीएसडी तो आपके सामने है ही, यहाँ से नहीं एंटर हो रहा है, वो वहाँ से आ रहा है. सो एंट्री फ्रॉम पल्मोनरी वेन मीन्स इट इज टेकिंग द लंग रूट, मतलब पल्मोनरी फिस्टुला है ना. सो थ्योरेटिकली आफ्टर 3 बीट्स, बट इतना डेंस फिलिंग होता है ना, इतना फास्ट सर्कुलेशन होता है. एक्चुअली पीडियाट्रिक हार्ट रेट 160-170 है, तो आप कब तक हार्ट बीट काउंट करोगे ना, जब तक आप सोचोगे 4 बीट निकल जाती हैं, तो लगता है वो एकदम आ गया. इट इज सो फास्ट, थिंग्स आर हैपनिंग सो फास्ट. सो आई शुड बी ट्यून टू सी ये कॉन्ट्रास्ट आया कहाँ से. राइट हार्ट फिल हुआ, लेफ्ट हार्ट फिल हो गया, एएसडी वीएसडी है नहीं, वो आप देख ही रहे हो. नो फिलिंग, राइट के बाद लेफ्ट का फिलिंग नहीं होता है, बट कॉन्ट्रास्ट वहां फिल्टर हो गया ना वीनस लेवल पे. सो आपने कॉन्ट्रास्ट दिया ऑन लेफ्ट साइड, यू डोंट सी, बिल्कुल ही नहीं. ओके, सो ये है, this is one of the patient clinically ASD, early fatigability, came with because right heart was dilated, so came for ASD only, and the issue was, this is SVC, okay, this is bicaval view, and here I don't see any defect. Okay, I am looking deep into SVC, trying to look deep into SVC. Something was joining superior vena cava. So not very clean, but when I had doubt, we went for for CT angiography, and this is bilateral SVC, this is left SVC, this is right SVC, and pulmonary vein was joining very high into SVC. Okay. Transthoracic echo or by T, both way I am not very happy with the finding. Transthoracic, obviously we did not have any specific diagnosis. With T wise, it was not sinus SVC type, sinus venosus ASD. Pulmonary veins were joining very high into superior vena cava. That's why you need further imaging to get explain your echo or clinical findings. This is significant mitral regurgitation, ASD again with significant shunt. So this is adult patient, so you can see how ugly the mitral valve is with significant mitral regurgitation. With MS, this is Lutembecker syndrome. So mitral valve should be looked very carefully. Tricuspid valve, mitral valve, both should be looked very carefully in patient with the pre-tricuspid shunt especially. This is an adult patient with significant pericardial effusion, ASD only, and she was I think 60 something, and so large pericardial effusion found to be ANA positive. So first we did pericardial tap, we took out this much of fluid, then we did proper cardiac cath study after 3 days of this pericardial tapping. All investigations were done for pericardial effusion, what is the cause. ANA came positive, it was not infective, it was transudate only, and we went for device closure. She is now almost 5 years post device closure. Hypertension issue is going on because she is a case of SLE, but device wise she is fine. Pericardial effusion, small pericardial effusion is persisting. So these patients become chronic patients. For ASD wise fixed, no recurrence of massive pericardial effusion after device closure. She is doing otherwise perfectly fine. So echocardiography tells you a lot for any defect. Clinical picture you need to keep in mind when you are dealing what you want from echo, that is also important. So you get anatomy, you get hemodynamics, you decide about the modality of intervention, you decide about when to intervene. If needed, go for transesophageal echocardiography and cath or CT or MRI. In totality, we need to give answer to the patients about the management. Like pediatric, we don't go. In adolescent onward, when windows become difficult, you need to see how you are able to define the anatomy. Okay, if needed, go for transesophageal. Pediatric में ज़रूरत नहीं पड़ती है. 12, 13, 15 साल तक windows are very good. Okay, 20-year onward, we need, if things are not getting explained, and when you want to decide about, you are going for device closure. So better to have anatomy clear before, you should not get surprised in cath lab.
For the rings, the child is small, and do we need to do a T in that case?
Like when windows are adequate, why to do? T is not giving anything extra, it is just adequate window. When windows are okay, so it is transthoracic or T.
Rings also?
Everything. I showed you complementary transthoracic and T view, that's why. So you have every information. Windows has to be, you should be happy with your imaging. Which imaging? That you need to take a call. There is no force. Adult patient, we sometimes decide. Like for VSD, we hardly do T. Okay, all decision we take on transthoracic echo only. So depend, am I happy with my imaging? Any doubt? In grown up, you can do T, is just hardly 2-3 minute procedure, this is nothing. But again, you need to be very safe, you should not create damage, esophageal erosion, everything is known. So we need to be very soft, we should not be aggressive. And a complete transthoracic echo is very important before taking for T. So patient is referred to you for T. I always do transthoracic echo as part of T and give a complete report of T plus transthoracic echocardiography. You won't charge for two imaging, but I can't go for T without doing transthoracic. मुझे पता ही नहीं मुझे ढूंढना क्या है. Okay, so transthoracic is compulsory before deciding or before doing transesophageal echocardiography.
Ma'am, can you show us a complete report of transthoracic echo in case of ASD also?
I showed you. Like one is we give the final impression, and segmental analysis. Okay, so segmental analysis will have everything: situs, solitus, levo, cardia, AV concordance, VA concordance, normal connecting systemic veins, no left SVC, normal connecting pulmonary veins, AV valves, mitral valve and tricuspid valve, this, ventricular septum intact with normal septal motion, outflow tracts are normal, pulmonary arteries are normal. So all segments you need to comment. Final impression is congenital heart disease, fossa ovalis atrial septal defect, itna millimeter with left to right shunt, with rims adequate or inadequate. Jo inadequate you mentioned that. RARV dilated means volume overload is there. Septal motion is paradoxical because of volume overload. TR gradient itna means PA pressure itna. Okay, no pericardial effusion. So that is your impression, and by that I am happy. Advise, discuss with the family about device closure of this or surgical closure of the defect. That carries my echo report, whether it is transoceanic or TE. So all segment you need to comment. I think ASD, yes, PA pressures you need to. PA pressure wise, ASD is a very difficult situation. If PA pressure even 60, with 60 PA pressure we need to be very, very careful before deciding about device closure. One of the patient I would like to share here.
This is your format.
Yes, thank you. So sir ने इतना सब बढ़िया बना के रखा हुआ है. So 55-year-old underwent ASD device closure in 2016. Doctor हैं, surgeon हैं, active life था, and he had some fatigability and all, respiratory issues करके investigate होते रहे, बहुत सारे TE भी CT भी हो गए ना. Doctors कुछ अजब अलग confusion चलता है उनका. 7-8 CT chest हो चुके थे उनके. हाँ, जब देखो जाओ रेडियोलॉजिस्ट फ्रेंड है, सर लेट जाओ, ठीक एक CT कर देते हैं, लंग्स ठीक है क्या. मैंने कहा सर आप अपने आप को जला रहे हो लिटरली, आप 8 CT इमेजिन करो. बट फाइनली ही वाज डायग्नोस्ड टू हैव ASD, एंड ASD, अच्छा ASD है, यही सबकी बीमारी है, ASD डिवाइस करो, ASD डिवाइस भी हो गया. TR was 60, कैथ लैब में प्रेशर सिस्टोलिक 60 के आसपास, एंड मीन प्रेशर was 36, not very bad for a patient. Precautionally fenestrated device was put, ठीक है, कि शायद ये मिसबिहेव करें. ओके, सो आपके पास एक पॉप ऑफ रहना चाहिए, तो फेनेस्ट्रेटेड डिवाइस भी लगा, ठीक है, ऑल. बट पेशेंट डिटोरिएट. ओके, अभी उनकी ये हालत है, ही कांट सिंगल स्टेयर, ही कांट वॉक. ही केम टू मी विद 10-12 साल के पेपर्स के साथ में उनका, और रेस्पिरेटरी करके चल रहा. एक बहुत पहला लंग परफ्यूजन स्कैन था विच वाज शोइंग फिलिंग डिफेक्ट्स. Okay, and that is very important actually. Filling defects किसी के lungs में हैं, so I mean some type of coagulation abnormality और कुछ भी तो चल ही रहा होगा ना. Especially PA pressure 60 अगर पहुंच गए तो obviously ASD is not the culprit. And if you go by history, ASD was definitely helping him during exercise, during walk, क्योंकि ASD बंद होते ही वो इतने sick हैं, वो बस लेटे हैं तो ठीक हैं, otherwise life is really bad for him. अगेन फिर 5-6 साल ऐसे ही गुजर जाते हैं. अभी आई एम सीइंग फॉर लास्ट 1 year पल्मोनी वेसोडायलेटर ही कांट टॉलरेट, उनको पूरा एंजियोडेमा हो जाता है. सो वेरी डिफिकल्ट, कई बार पेशेंट बहुत डिफिकल्ट होते हैं. डायरेटिक ही कांट टॉलरेट, वेट लॉस चल रहा बिल्कुल, लिवर नहीं है, बट हार्ट इज नॉट एक्सेप्टिंग दैट डिवाइस. ओके, नाउ ही हैज बीन डायग्नोज्ड विद हेपेटोसेलुलर कार्सिनोमा. सो इतना कुछ हो गया ना. अब हिपेटोसेलुलर कार्सिनोमा, इतना रेडिएशन मिला है, किसी का 10 CT हुआ प्लस 2 कैथ हो गए. सो यू कैन इमेजिन द डोज ऑफ रेडिएशन ही हैज रिसीव्ड. सो प्राइमरली पैथोलॉजी गॉड नोस क्या था, लंग्स में परफ्यूजन स्कैन तो डेफिनेटली था जिसको कभी बॉदर नहीं किया गया. फिर डिवाइस भी हो गया, फिर रेस्टिंग TR ग्रेडियंट 27-30 आता है. रेस्टिंग PA प्रेशर आर नॉट हाई, बट जब आप एको लैब में उसको एक्सरसाइज कराते हो ना, RV ऐसे गैस्प करने लगता है लिटरली. हाँ, सो बट वो सल्टना, वो बोसेंटॉन मैसेज कुछ भी नहीं टॉलरेट कर पाते, कुछ भी नहीं. टेडालाफिल 20 mg, एक एडल्ट 55 year, इमेजिन, उनसे कुछ नहीं लिया जाता. बस ASD was saving him actually. तो एडल्ट ASD विद बॉर्डरलाइन PA प्रेशर, इतनी अजीब अजीब सी हिस्ट्री ना, यू कांट इग्नोर. ASD को डेफिनेटली आप ब्लेम नहीं कर सकते हो इतनी लंबी हिस्ट्री के लिए, बिल्कुल नहीं ब्लेम कर सकते हो. लंबी हिस्ट्री है एडल्ट ASD की, तो प्लीज डोंट टच दैट ASD. ये सब बहुत डरावने केसेस हैं. कुछ कुछ केसेस हम लोग के सामने आते रहते हैं क्योंकि वो फिर हर जगह जाता है ना. जब उनको दिक्कत हो रही होती है आफ्टर डिवाइस क्लोजर, देखो, सो वी ऑल नो दोज पेशेंट्स, और वो बहुत वरिंग होता है. एक डॉक्टर जो बिल्कुल बेड पे आ गया, जो सर्जन बहुत एक्टिव लाइफ जी रहे थे विद दैट ASD, नाउ ही इज हार्डली डूइंग एनीथिंग. कुछ भी नहीं है हमारे पास करने को. फेनेस्ट्रेशन काम कर रहा है, तो रेस्टिंग में फेनेस्ट्रेशन लेफ्ट टू राइट होता है, बट उन्हें जो बड़ा पॉप ऑफ चाहिए था वो नहीं है. आप उसको OT नहीं ले जा सकते. 6 साल पहले ASD बंद हुआ है. अब ऊपर से हिपेटोसेलुलर कार्सिनोमा डायग्नोस हो गया, तो कॉम्प्लिकेटेड सिचुएशन है एक्चुअली. Probably for me, what I explained them, we cross that communication, fenestration, we dilate that, put a stent there and open. So we can give a sizable ASD to him. That is the only solution we have, mechanical to help him. But with all liver and lung issues, what he will tolerate, that is difficult. मतलब एकदम अपना life फॉल्ट किसी का नहीं है. मतलब आई एम नॉट सेइंग कि इंटरवेंशन इज टुक ए रॉन्ग कॉल, उन्होंने फेनेस्ट्रेटेड किया, बट द थिंग इज ना, ऐसी वाली हिस्ट्री में ना मुझे लगता है एडल्ट ASD नहीं करना चाहिए, क्योंकि क्लोज करना इज वेरी इजी थिंग, पुटिंग अ मेटल इन हार्ट इज वेरी इजी थिंग. आप किसी को भी बंद कर सकते हो, उसमें कोई इशू नहीं है. वो एक्चुअली सर आप सोचिए ना, उनकी इतनी मोटी फाइल, मुझे 1.5 घंटा लगा उनके साथ में. वो मेरे घर आ गए विद ऑल फाइल्स, एंड सो एंड उनको भी नहीं पता था उनको कभी परफ्यूजन डिफेक्ट से डायग्नोज हुआ, बिकॉज वो इन्वेस्टिगेशन कराते ही जा रहे. पेशेंट ये बात करना एंड टेकिंग द हिस्ट्री इज वेरी इंपॉर्टेंट फॉर CT अकॉर्डिंग ना CT होता रहा, CT नॉर्मल है. Yes, some type of that thing, hypercoagulable stage, and because of that lung got compromised. Because of that he was having PH, which is got complicated now. क्योंकि वो with exercise it was helping him, that ASD was helping him. So rest, जब आप कैथ करते हो पेशेंट टेबल पे रेस्ट में है, तब आपके प्रेशर और जब चल रहे होते हो, हमारे पास वाली हीमोडायनामिक नहीं होती हैं. जी सर. ओके, ठीक है. आई थिंक पल्मोनरी वेन्स हम नहीं करेंगे सर, है ना हमारा. हाँ, मतलब ये इम्पोर्टेंट है कि हमारे. हाँ जी, ठीक है.
So we'll start with this presentation.
Just hold on. Let's continue. Dr. Neeraj is going to show us line contrast in congenital heart
Yes. So we will see 3 or 4 imaging only. ये मशीन थोड़ा यहाँ पे मुझे बोर्ड चाहिएगा. I need the board. Okay. So we have discussed today also a lot of things about saline contrast. I will show 2-3 cases just to demonstrate what ma'am has said till now. This is first case. You see the video? Contrast is coming. Saline contrast we know, bubble. We make the bubble by 3 syringes, make the micro bubbles. Let it come again now. Let's now start focusing. Focus on the RA first. This right side is RA. So this is RA, this is LA. See the RA filling and then LA. Immediately. What is this now? ASD, but I can't see ASD, maybe some PFO. This is post-op case. I am trying to see why a child is desaturated. See there are multiple scars, maybe VSD or something. I don't remember. This may be a post-op repair. See the IVS and the RV bulging. I am looking for the contrast across the PFO to see the cause of desaturation. So the question here is immediate filling. Okay, now why the right to left shunting is happening? Because you see the RVH, RVDP is high. In ASD, RVDP is high, that's why left side is filling rapidly. Now we go to the second image. This is different, not the same patient. RA filling, and it takes time to come to the LA. See this, keep seeing this again, let it come again. बोर्ड चाहिए मुझे, क्या हो गया? बोर्ड कहाँ हटा दिया? Again, let it come. Focus on the RA first, and then see, LA is still not filling. It's taking 3-4 beats. How many beats is not important, depending on severity of AVM. This is AVM. What is? ऐसा कैसे चलेगा बोर्ड? ये क्या कर रहे हो? अच्छा हाँ ठीक है मुझे लगा हटा ही दिया यहाँ से So what is happening is RA fills, then normally what will happen if I put a contrast in my body, what will happen? RA will fill, RV will fill, and then to the pulmonary arteries, after that to the, I can't hear. No, pulmonary artery के बीच में LA के बीच में कुछ structure है एक. There is a big structure between pulmonary artery and LA. What is that? Lungs. Lungs are remaining. So that's what we have to understand again. This go with this concept. So you have 4 chambers, pulmonary artery, and LA is here. Then lungs, and then pulmonary veins. Okay, so the in saline contrast should come normally RA, RV, and air should get dissolved in the lungs. So the left side structure should not get any air. Pulmonary veins should not get any air in us. In my lungs, they will resolve all the oxygen, CO2, air, everything. Now, when I see filling of LA by contrast, what does it mean? What are the possibilities? One is communication at what levels? One is atrial level, VSD level. But if VSD level communication, LA will not fill, LV will fill. If LA is filling, then one more communication is pulmonary artery to pulmonary vein. It has to before lungs. So that is called pulmonary AVM, AV malformation. The first patient has PFO, intracardiac shunt, immediately filling. Why? There is no need. But this one will take some beats, and then this will go, and then this will go. So it takes some time. It will need some time, 2-3 beats, maybe 4 beats, but it will fill late, not immediately. That we have to understand. This is the important concept and very easy concept. When to do saline contrast? When intracardiac is normal, and I am looking for cyanotic cause. Lungs are not explaining, lungs are normal, child is not distressed, and child is cyanotic and clubbed, then I am looking for AVM. Sometimes X-ray may give a clue of AVM, like last day we showed some X-ray, may have some haziness on one side, but this is not a permanent feature. And when you diffuse AVM all over lungs, you will not find any AV malformation on X-ray. There are micro AVMs. So when you have a child who is cyanotic, when you are starting echo, I told you yesterday, you do the pulse oximetry, this showing desaturation, but you are not finding any disease for desaturation. This is the next step. Okay. Now, further utilization of this structure now. What are the further steps? Sir showed one case yesterday. What was that case? Anyone remembers? Contrast echo case? PDA. PDA is what? This is the PDA. When the PDA air comes here, goes into this structure, and then goes into a descending aorta. So heart will not fill into PDA. The descending aorta will fill. So you have to focus on the descending aorta when you are looking for PDA shunting right to left. If PDA shunting left to right, it will not fill descending aorta. So here we are looking for descending aorta. Now beyond this, now ma'am showed unroofed coronary sinus. How do you pick up unroofed coronary sinus? So this is LA, this is RA. Normally there is a innominate vein, LSVC, this may or may not be there, but LSVC, I am talking about LSVC, left superior vena cava. Normally it comes like this to RA. Okay. Systemic veins should come to the RA, all systemic veins, whether left, right, or whatever, they should come to the RA because they are getting the deoxygenated blood. Now, if there is unroofing, means there is a whole, some communication the roof of the coronary sinus is coming into the LA. That is unroofed coronary sinus. But madam told very interesting point. When you have unroofed coronary sinus will not dilate. So how do you pick up? Suppose again, I have a VSD patient or ASD patient shunting left to right, but child is cyanotic. I am looking for whether I have LSVC draining into LA, that is either directly or by unroofed coronary sinus. But in both situations, you will not see dilated coronary sinus. So there is no clue on the echo. Only clue is when we do echo, we see LSVC separately also. We all pediatric cardiologists are accustomed to see the LSVC also. When I see LSVC and coronary sinus is not big, I am looking for unroofed coronary sinus. But for you, so again, I will revise this sentence again. If coronary sinus is not dilated, but LSVC is seen, that means what is this? Unroofed. But you have to be able to see this LSVC then. But some people are not accustomed to see this. So what do you do? Left arm. Use the left arm for injection. Left arm for injection. Bubble will go to the coronary sinus and it will fill the. But what about RA? It will not fill unless you have ASD and shunting left to right. So RA will fill late. LA will fill earlier. Similarly, if RSVC is draining into LA, you put a contrast in the left arm. Normally RSVC has a nominate vein. So whatever you put contrast into left arm, RSVC and then again LA will fill earlier. You understood? So now let me show the next video. This concept is clear. Only then you can understand the further presentation. So when filling of LA is happening directly without filling RA, that means I am looking for SVC draining into LA or IVC is draining into LA by post-op ASD closure or congenital in situs azoospermia cases. But you have to understand, when I am filling of LA directly, remember this board, then you are talking about systemic vein draining into LA. This is a child, 5-year-old, cyanotic child, ASD shunting left to right. The child has a bilateral SVC. Let's see this. First see this. So I told you we can see coronary LSVC. See, this is the LSVC. In the high suprasternal view, you can see this LSVC draining into blue color. Oh, this pointer is not there. The blue color. So let me run again. LSVC means that's coming from up. So what color? See the window? This will coming like blue color. Okay. Play क्यों नहीं करता है? I don't know why I am not able to play this again. Okay, now कहाँ गया वीडियो? यहाँ पे ना, यहाँ पे हाँ, मुझे ना स्क्रीन लार्ज किए बिना ही डिस्प्ले कर सकते हैं क्या? हाँ, ये डुप्लीकेट नहीं हो रहा है इसलिए. Yes, now I should run. Okay, देखो जरा. हाँ, okay. Okay, so this is the aorta, this is the PA, and LSVC is coming like this, blue color. Suprasternal slightly higher. See, this LSVC comes from this view. So you have to see the LSVC come into and the roof of the base of RA and then goes to the RA, to the LA to the RA. LSVC will go through the base of LA to the RA. It has to come to RA. Pulsatile, no? Venous and arterial structure are different. No, pulsatile. Aorta veins are different. Aorta is pulsatile, SVC is never pulsatile. A venous structure, no? PDA will not come so to the LA. It's the LA, no? It's LA. You are coming towards LA here, not to the PA. Now, anyway, if you put a contrast here, what will happen if I put a contrast in this patient? what structure will fill? Either RA or LA. If I put a contrast in the left arm, LSVC comes. If it's draining into LA, what will fill? LA. If it's coming to RA, it should fill RA. So let's see. So behind the aorta you have structure of LA. So if this structure is filling, that means you are talking about LA. Let's see the contrast now. Okay, I will escape this and go to the videos. Leave it. Okay, I think some problem with the SVC. Okay, again, let me see it again. Contrast is coming. See what is filling? LA. Now, if SD is there, RA is also fill. But first structure is, see this. So somewhere here is the unroofing. Okay, this is clear till now. Now we will go to the, so this is the disease where you have ASD shunting left to right, but child is cyanotic. This is clear till now. Okay. Now next structure. So 14-year-old child, again normal echo, cyanotic child. During COVID times at home they found that there is saturation of 85%. I am doing a left arm saline contrast to see AVM or LSVC. I am not sure what is happening in this patient. I thought AVM would be there. Child has 14-year-old, child is cyanotic and no other disease in the heart. So I thought this is AVM or AV malformation. But see the echo now. So this is the contrast again, SVC to LA. So a left arm contrast, what is filling? LA. But this patient did not have LSVC. First filling, see focus on LA here, this is LA.
RSVC to LA.
Yes, this patient had RSVC to LA because I am sure there is no LSVC on color. Like previous structure, patient has LSVC, this patient is only RSVC. There is no LSVC in this patient. So this patient underwent a CT also again to confirm the RSVC draining into LA. But when the LA is filling directly, I am looking for structures like this, RSVC or LSVC draining into LA. Yes, these patients do have murmur, sometimes in the back, sometimes in the front, but it's difficult to appreciate. They are not very harsh murmurs. Now this is one more case, I think last. This is slightly complex. If you understood this much, only then we can go ahead in this structure. This is the last case for saline contrast. Let's see. Let's see if we try to understand this disease. So, what would happen if IVC is draining into this left-sided atria? I am calling it left-sided atria, I am not calling it LA. Lot of people would not accept this, that's why. Lot of people will not accept IVC draining into LA because even I am not accepting this. So I am saying there are two LAs. Okay. So, but anyway, if this is the left-sided atria, this is the right-sided atria, this is the left-sided atria, and if IVC is draining into LA, how do you pick up? So that means contrast has to come from lower limb, not from upper limb. So let's see what happens here. So this child is a cyanotic child. So this patient has interrupted IVC and aorta was to the left of spine. So I don't know what is situs here. So we call it ambiguous because I am not sure about IVC. IVC is interrupted. And otherwise levocardia, AVVA concordance, no TGA, normal pulmonary veins, small ASD left to right shunt, LA-LV is dilated and mild MR. Now here clue was child has small ASD and we have LA-LV dilatation. ASD should have what structure, what dilatation? RAR. This is a small child, 1 year old something. So this is document interrupted IVC basically. Hepatic veins are coming to directly to RA, but IVC is interrupted. This is the posterior structure, venous structure going behind the spine. But anyway, let's go ahead with this plan. RA, and nowhere. I can't see IVC draining, nowhere. Subcostally, I see LA, LV dilated, small ASD shunting left to right, some MR. You can see LLV dilatation, slightly prominent LL. This is NRGA showing some MR, fourth chamber view showing some MR, LALV is prominent. The question was, there is no cause, my MR is not significant, but we have LLV dilatation. So NRGA, the aorta is coming and there is no parallel vessel, MR again. Again short axis view, you can see a coronary sinus here dilated. You have a coronary sinus which is dilated. That means unroofed coronary sinus is out. The coronary sinus dilatation means unroofing is out. Coronary sinus is draining into RA. Understood this part? Otherwise, this has to be not seen. The bulb will not be seen if it is unroofed. Similar picture, I am seeing the coronary sinus LA. So till now, what I have as is, I thought maybe unroofed coronary sinus draining into LA, because still I thought maybe small fenestration is seen in the coronary sinus, which is draining into LA, causing desaturation. Interpret as IVC draining into LSVC to LA, because I have seen interpreted IVC, which might be going from down to LSVC and then coming to the coronary sinus, and maybe there is a route to the LA. Small ASD was left to right and LALV is dilated. So these things I was almost sure till now. Understood this part? I have a coronary sinus draining into LA, the coronary sinus dilated, and I have interpreted IVC and maybe LSVC to LA. That's what we are saying. It's a circle only, it's not draining here. Circle means this is prominent coronary sinus. It's not draining into LA. Draining means it has to fold into R, Now we thought, let us sort it out. CT was done, they were not sure what is happening. So Susan is there. Susan, if you were there in this patient, we put 3 cannulas, right arm, left arm and lower limb. Small child. So we thought, no, we did the paralox. You know about the local anesthetics? So the child is not crying. We did paralox, preparation in the morning. In the afternoon, we call them again so the child is calm. And we started with the 3 cannula, right arm, left arm and 1 lower limb. So this is contrast from the left arm. Let's see. This is LA, LV. What is filling? LA. Directly LA is filling. So we knew something from left arm is coming to the LA. This one we were sure now. Either LSVC or IVC coming through LSVC, like this way IVC coming to the LSVC. But till now, left arm means LSVC is not, IVC is not in the picture. You are talking about LSVC. So we are sure LSVC is coming to the LA here. See this, RA is not filling. And then after some time RA fills. That means ASD shunting left to right. From right arm, that means I am thinking RSVC, I am looking for RSVC. Where is draining? Let's see again. Let the bubble come again, focus now. What is filling earlier? No, LA. See again, see this again. Right arm injection. Focus here, let it come. Okay, so similar because ASD is just there. Then from lower limb, from the foot, I am focusing on the LA. And again, the child moved by a time, but again I will show you again, or maybe in this picture. Again, see this LA, or behind the aorta is LA, focus on the LA. See this? Fills LA first, then to the immediately to the RA, because ASD is there on the same plane. LA. That LA is there or not, we don't know. Left sided atria. So final diagnosis we thought of total anomalous, not pulmonary, systemic venous connection. So compared to TA-PVC, this is TA-SVC. Both SVCs and IVC draining into LA, all pulmonary veins to LA. So that's why LA-LV is dilated, because everything is coming to LA. Like TA-PVC, you have RA dilatation, here you have LA-LV dilatation. And SD has to shunt left to right, otherwise child cannot survive. Like a TA-PVC, SD has to shunt right to left, there you have obligatory left to right. Always keep hemoglobin in mind when you have desaturation unexplained. So what are the hints to systemic venous? When to look for it? When to do so many things? Pre-echocardiac suspicion. Central cyanosis with a normal cardiac examination. ECG may show some poor RV forces because RV is small. So we are talking about poor RV forces. X-ray may show cardiomegaly in terms of left side dilatation. If hypoplasia of RA is seen, may be good. QP is mostly low. Pulmonary flow is low because shunting is happening from left atrium to right atrium. Nothing is coming to directly to the RA. So QP is low. Pulmonary flow is low. So if LA fills earlier than RA, you are talking about left arm, that means either LSVC or RSVC draining into LA. Right arm vein, RSVC draining into LA, or if leg vein, IVC is to LA or via SVC. This patient, IVC was draining via SVC. Anyway, this is a complex case. This one, ma'am spoke slightly yesterday about this part. If you have small RA and RV and dilated LA and LV, and ASD is left to right, LA-LV dilatation, ASD left to right, suspect systemic venous anomaly. But if ASD is right to left, as ma'am said, RV is small. That means that's why RVDP is high, RV is small, and ASD will shunt right to left. This one I will describe on this again on this board. So if LALV is dilated, ASD shunting left to right, and child is cyanotic, that means veins are coming to this side. But if RV is hypoplastic, then ASD shunt has to go from right to left, because RVDP is raised, RV is small, and that's why ASD will shunt right to left. Like a tricuspid trigger situation, tricuspid stenosis situation. And both will be cyanotic.
Sir, in case of PDA or VSD, saline complex pathway, which arm should we
Any arm, doesn't matter. You are talking about system. I normally do left side because we want to rule out associated LSVC also. So that's why you prefer left arm in all situations actually, because you want to see associated LSVC draining into LA. That you can profile by the left arm. Surgery was done, systemic veins well drained to RA. This patient underwent surgical repair, went home in 5 days, child is doing well. All veins were draining, converted to the RA. So it was simple surgery actually for us. Sorry? There is no amount, Some take 10 ml syringes, just put 5 ml, just keep seeing, whenever I see the contrast, 5 ml 2-3 ml should be enough. 5 ml may be enough. You are talking about a saline contrast. Saline contrast is a saline only, no? It's not a contrast. It doesn't matter. Okay.
What was the final outcome of this patient?
Surgical repair, went home in 5 days.
He had that draining into left.
Left atrium. And surgical also they say it's a left atrium. Surgically proven.
So bubble, like when we agitate and then do this bubble, can I have like embolism?
Yes, that's what sir said. But you know, you make micro bubbles, fine bubbles, push yourself to a doctor, not to a technician, because they may push larger volumes on the behind of syringe. You have large bubbles which may go into the system. So keep the bigger syringes, 10 ml syringe, put 5 ml, and keep the rest of the bigger bubbles on the back. That has to be done by a doctor, not by a technician.
Because once the air goes into the system, then it can be catastrophic.
Yes, that's what sir said yesterday.
As soon as you push in your left arm, whole of the system went into left side system. Some of the bubbles went upstream in the brain, some in before when the patient started collapsing. So we used our cath lab language. We used to inject air in upper colon. Whatever we used to do, put it in a fountain, decadon, whatever we had check up the blood pressure. Saline to check up the blood pressure. So we do the same thing. Here also will show you a contrast, but we give you only very small contrast because this is not a large area. So I'm making just one or two. So we have to categorize it. And we always keep pulse oximeter and everything at our disposal. So we very carefully, like we just don't do it like we do it every time, blindly we don't do it. In fact, in this patient is not required at all. She's all set ready. Dr. Manish is all set, and we are going to show you 3 dimensions. How do we look the margins for air? Because that is the most appropriate usage of 3 dimensions in translucent.
So, I will take your leave now today. I have some emergency in the hospital. So I have to go here. I have to stay for a longer time.
Just 2 minutes.
Right side. This side. So this is communication. This is
Only thing is AVM you want to see. I have only one choice. I got the
so. बेटा कितनी एज है आपके कितने साल के हैं 11 so this is a 11 old beautiful girl with me and starting a sequential echo in her so this subcostal short axis view at the level of diaphragm. Okay, so you can see this is where is marker point. हाँ वो better था. Yeah. So before going to 3D or 4D, 2D is important. So 2D we all have to know. So this is your liver, here stomach. So this is one channel which is collapsing, and this is pulsatile. So aorta and IVC. Okay, color wise you can see this is aorta pulsatile flow, and this is collapsing again blue flow into the inferior vena cava, and pulsatile aorta. Just to complete the thing. In all patients we don't need to do, but we in early part of our career ideally should do all these numbers. Next, and that pulsatile flow also shows there is no significant coarct. Okay, or means no arch narrowing basically, so that rule out that particular part. The velocity is good, means patient is not in low cardiac output, so that gives you many things. Heart rate is okay, pulsatility is good, no proximal obstruction is there, so you are getting many information from them. Then from there, it was my short axis view, I just tilt anteriorly and I am getting the coronal view. Okay, so most posterior plane again, so atrial plane and the ventricular plane. When the atrial plane, I have interatrial communication. This is right lower pulmonary vein, this right lower, that is left upper pulmonary vein, ASD is there, this rim is there, though it is borderline, and here this one appear deficient. Okay, next. So with color, what you see, it is a bidirectional shunt. Saturation is 80-85%. Okay, so bidirectional shunt is across that interatrial communication. There is no significant regurg here, but here I will profile this regurgitation. Right heart is dilated. Okay, this is IVC, which is okay, receiving hepatic veins, and nothing is joined into the inferior vena cava. This is right upper pulmonary vein, right lower pulmonary vein going into left atrium. Okay, so hepatic vein part is okay. SVC is normally draining into right sided atrium, and again communication is there, which is bidirectional, intermittently almost all getting right to left only. Next, coming to 4th chamber. So you can see there is tricuspid regurgitation, which is definitely more than mild, moderate tricuspid regurgitation. Right heart is dilated, left heart is okay, ventricular septum is normal, mitral valve is normal, just trickle of mitral regurgitation is there. There is no mitral stenosis, and my gradient is 100 plus. This is so severe pulmonary arterial hypertension with atrial septal defect is there, and these are the patients, they have a primary component. In isolation, like we have, at least I have not seen any direct relationship between age or size of ASD or pulmonary arterial hypertension. So ये तीनों अलग अलग चलते हैं. It's not large ASD will develop PH. So anything can happen. She's so young. At this age, she getting a TR gradient of 110, 120 is something, is definitely not because of atrial septal defect, and obviously we are not going to close or even remotely think. But before commenting on that, I have to say that pulmonary outflow tract is normal. So it is not because of PS this TR gradient is. So RV pressure are high. Till here RV pressures are high, ASD is there, VSD nahi hai, left sided issues are there. Pulmonary veins 3 I have shown you, which are normally connecting, SVC, IVC normally connecting. Shunt is bidirectional, so I have to go towards the outflow tract. Next. So I have seen, means LVOT, RVOT both were normal, and I went to parasternal short axis view. Go back. Yeah. So this is a good view for adult patient. So grown-up patient, if you don't have subcostal windows, so in apical 4-chamber views, rays are parallel, so there are very likely we see dropout in a fossa willis area because that is thin. But here rays are not parallel. So this is a good view. Yes, parasternal short axis view. Yes, yes. Yeah, modified. So that will that you can differentiate true ASD from dropout from this. You can take help of this view. Again, you are seeing the pulmonary veins, aorta in short axis intermittently is coming. Direction of shunt also you will see here. Dilated right heart you are seeing here. Parasternal long axis view to look for everything. Plaques with the M mode, huge right ventricle, more than LV size right ventricle is. Okay. Pulmonary arteries are dilated, big pulmonary arteries are here. Coronary artery, simultaneously we have a look on the coronary artery. So you can see this is left main, which is LAD and circumflex, plus right pulmonary coronary vein, coronary artery. Okay, so this is normal. We, as a policy, we look for the coronary in all patients when we are doing, especially post-COVID. One is Kawasaki, it was there. Now post-COVID, cardiac involvement with coronary dilatation is a big number we are seeing. Still we are getting coronary dilatation. So aortic arch in long axis view, okay, and short axis view you were asking color flow, there is no arch narrowing or anything in that. So going to, one is, where is my probe? Here. So suprasternal view in short axis, we, for left SVC and for things we were discussing and you all were having, beta ye hata de, bas 2 minute ke, niche rakh lo, upar dekho aise. So my probe is like this, pointer is directly towards left, okay, not tilted. So I am going to put in suprasternal notch and look like this, okay. So this is my probe. Straight left, yes, 3. So this is innominate vein, this is right SVC, this is transverse arch in short axis, this is right pulmonary artery, this is left atrium receiving pulmonary veins from both sides, okay. So from upside down you have all 4 things, innominate vein, transverse arch, RPA which is huge, and left atrium, okay. So this is the short axis view. If I look towards left, here I will get left SVC if it is. So the channel will be seen here. You may see innominate or may not, depending on whether it is present or not. So left SVC, left innominate subclavian vein come here and descend downward, going into left atrium or coronary sinus. Okay. So this is the area where you see left SVC. So here I don't have any SVC, left SVC. It is right SVC only, good innominate vein. It is there only, just I am tilting it towards left. To open the left sided structure, to open right, I tilt it towards right. So that I could see this is first arch vessel. I need to demonstrate that it is dividing. So this is carotid artery, right carotid, and right subclavian artery. Okay. So this division just to demonstrate. If it is left arch, in this case, if right, that demonstration will be seen on opposite side. Okay. So short axis view is this. For long axis, you have seen so many times since yesterday. So this is my long axis view. Here, aorta will RPA will be in short axis. In that view, transverse arch in short axis. Here, right pulmonary artery in short axis in long axis view. So aorta is wrapping around this. Okay, the first branch, second branch, third branch, first innominate division I have shown you, and left carotid and left subclavian artery. Sometimes you see vertebral arising separately. You will see 4 branches or 2 branches only when common origin of innominate and carotid artery. So variation in the arch and branches is being seen, but again you need to follow which one is going where. Okay, because vascular ring is another important thing, should be in your mind. So that is the suprasternal view. Now going towards demonstration of atrial septal defects. So this is modified in between apical short and long axis view. Okay, so this is parasternal short axis view. When I am going to at the level of aorta, because my defect is slightly posteriorly, it is fossa valis only. So this is aorta, usual short axis view, pulmonary arteries are dilated, and here this part is not, is sort of more of intact, and slightly posteriorly while I am looking, I could see the defect. Okay. So I need to modify my position. Now we'll go to 3 dimension. So this is the communication. 2D with depth, you can say, we are seeing, you can see the pulmonary veins, very clean lumen you can see in the pulmonary veins, you can see mitral valve, but my focus is at the atrial septum only. So this is the deficient rim which we are seeing. AV rim is also not very great, so it is a bigger defect. Show from RA side. Okay, so this is the defect. This is right side, the transverse section, the section is from right side. So right atrium, atrial septum, and this is the defect. Okay, this. So these rims means atrial rim, posterior rims, that part is defect. While anteriorly, as I was towards the aorta, my rim was okay. Okay, so sort of eccentric defect, and this is hardly rim, borderline rims. So towards the AV valve it is better, towards the aortic valve better, but posterior part is deficient. Okay, and irregular. Like now, sometime in on 2D we take patient for device closure, and if I measure in this direction, my ASD will be smaller. Here it is much bigger. So obviously that's why we have to take dimension on 2D from all views. So 2 perpendicular view plus oblique view. Otherwise we will have issues deploying device in cath lab. Size to theek liya, why it is not getting fixed? And this is the reason, because it is, you can see how irregular it is. Okay, here the size is different, here it is different, and when you have 2 separate defects, sometimes you have just a tissue here in between. So this is quite irregular type of defect, and that thing you can get only by 3D or 4D echo, not by 2D. So this image giving profiling this atrial septal defect is beautifully you can see by 4-dimension echo. She is having quite bad cough, so obviously cough cannot lead to a 120 gradient of tricuspid regurgitation, but that is also affecting her gradient and the things. Okay, any other thing you want to know? So short axis, it is bad, this right heart is huge, it is just compressing, suprasystemic PA pressure, you can see the septal motion, it is decay, in fact it is, during systole it is bulging towards left side only. So detailed evaluation, cath for hemodynamic assessment. Another thing, just upside down. When there is pH out of proportion to shunt lesion, hepatic should be looked after, should be seen. Sometimes there is extracardiac portosystemic shunt, and because the hepatotrophic factor is bypassing, it's not going through the lung, you may have early development of pulmonary arterial hypertension. So we as a protocol always check for hepatic veins intact, IVC normal, okay, plus in that case you have accessory channel into the liver, and if doubt we ask for radiology opinion, CT to look for the hepatic vasculature, and if some channel is like that, you go for the plugging of that. That is a thing, that rare anomaly, but should be. So any PH in this age, she is very young to have pulmonary arterial hypertension. So primarily component, or it is secondary to something. So secondary causes we should be looked out. Obviously, ASD is not the reason to blame for the pulmonary arterial pressure. Structurally, I am fine. My pulmonary veins are okay. My outflow tract is okay. So for me, X-ray is important. My liver evaluation is important. Like chronic liver disease patients, because of absence or no formation hepatotrophic factor, they also develop pulmonary arterial hypertension. They also develop pulmonary AV fissulas. So that part simultaneously should be looked for. So lung, heart, liver, they everything work in accordance and should be checked. Okay? Yes, before giving this name idiopathic, we should rule out. Yes, if we have ruled out, this is ASD is not the culprit actually. ASD is helping her. If we think about anything doing for this ASD, it is cause, like one is idiopathic, female patient, okay, so is always there. Yes, secondary causes should be connective tissue disorder, liver disease, pulmonary disease, chest X-ray, CT, if needed to be done, cardiac cath to look for the pressure and response to the vasodilator. So a detailed evaluation is needed. Okay, I think we have covered all topics. You are too much into congenital. You have received that heavy dose of congenital. Or
Shrikant, yeah, bana ke dikhao zara. We are not going to inject her because the ASD is such a large amount of ASD. So, and she has PA pressures are already very high. So we are not going to demonstrate in our case. But we will show you how to make a agitated contrast ready for injection. He'll use two 10 ml lockable syringes, one 3-way cannula, and a normal syringe. 5 minutes okay.
pediatric, like आप ऐसा लगता है ना, like if I give it 10 ml, I will have a better view imaging, but you have to put more pressure. 5 ml give better imaging, especially in pediatric. Obviously this volume is enough, और बहुत अच्छा contrast आपका 5 ml से आता है, and blood also act as a contrast. So if you withdraw blood, someone is not there to help you to make contrast, because आपको दो हाथ चाहिए होते हैं ना, कि एक जना push कर रहा है, pull कर रहा है, or you are that expert, that is also good. You withdraw blood, it gives a beautiful imaging of the contrast.
Why you use this 5 ml lockable syringes are not available.
We do with this, yeah.
They start slipping. As soon as saline leaks
Yes,
out, they
yes,
start slipping.
yes. Ideally, but ठीक है, सब कुछ हमेशा नहीं होता है. So we should know the limitations. जो मिल जाए उससे हमें best लेना है. That should be the. Dr. Subin is here with us. He is from Nepal. He is with us in Max. Yesterday when we were doing contrast echo on that adult, I usually take help of other person, कि एक तरफ से मैं push कर रही हूँ, एक तरफ से आप कर रहे हो. This is the way I do. But उसने इतना perfectly ऐसे बनाया ना, dense एकदम.
This is what has been done at the master.
Yeah. So for me, मैं ऐसे पकड़ती हूँ and yeah, push. So we two should be in like ना understand each other कि मैं push कर रही हूँ, आप क्या. So this is the way the dense saline is being, dense contrast is being formed. Okay, but अकेले भी आप कर सकते हो. So sisters mostly do like this, है ना? But आपको support चाहिए क्योंकि 3-way किसी को तो आप अपने आप से support करो या आप दूसरे की help लो, और अकेले करना सीखना पड़ता है क्योंकि आप कब अकेले हो पता नहीं चलता, है ना, कब आपको ज़रूरत पड़ जाए, इसलिए बेटर है कि सब तरह से करना सीखो. 2 जने हैं बेस्ट है, ओके, उसमें ठीक है, वो पुश कर रहे हैं एंड है, वो मुझे पुश कर रहे हैं, मैंने रिलीज कर दिया, जब मैं पुश करी उन्होंने रिलीज कर दिया, ये बात हम इनडायरेक्टली समझ जाते हैं, ओके, विदाउट लुकिंग एट ईच अदर वी नो व्हाट हु इज डूइंग. फॉर द फर्स्ट टाइम आई एम इंटरेक्टिंग विद हिम एंड उसने समझ लिया कि हम क्या कर रहे हैं, तो ऐसे ही मतलब यू अंडरस्टैंड योर.
This is what the contrast is, and just rotate and push.
And meantime, one person is ready to make a 4-chamber view, and you just yes.
Quarter ml of air. So this is one syringe is full of saline, and other syringe is just quarter ml of air. And as Dr. Mani said, we try to pull in the blood a little bit. So that's blood along with this air and saline gives an excellent contrast. Contrast is saline with a bubble, air. That is contrast. Is not a true contrast. Since we agitate them completely, that's why we call them.
Air is contrast
Air is contrast.
and agitated saline. That's why you can't directly push air low. Yeah, no, you can't do. This 5 ml syringe. Yes, yes.
How much time it will stay?
It disappears immediately. Immediately.
You are free. Yeah. आपको ready करना है, and your patient is ready, machine is ready. You have prepared it and just push it.
One is scanning, other is pushing.
The pressure is churning it. That movement. तो वो जहाँ आप रुके वो भी रुक जाएगा.
Oh. Yes, obviously.
तो आपने ready किया, सब कुछ ready है, आपने तैयार किया क्योंकि हमेशा आपके पास एक जगह नहीं है assist करने को आपको, तो आपको smartly अपना time deal करना होता है. चले, बढ़िया रहा, I think.
We'll have one more lecture. Dr. Prashar is on his way.
Okay.
So we'll cover, we'll have a photograph together. All of us can come and stand, and because it's always a pleasure. And I've heard you many times before, but this is like real personal kind of a thing, like when we had a good interaction.
Yeah, and the small gathering is more meaningful actually.
It's like standing together and having a good interaction.
Yeah, one-to-one. Otherwise, lecture and
Right on. Amar, right on. iPad, iPad. फोटो खींचनी है भाई, जरा कैमरा में जूम कम कर लो. बस ऊपर चले जाओ. अब बस गिरना मत. अब गिरो तो लैपटॉप ठीक रहना चाहिए. Then we let's pay our tribute, respect to Sabha, to man. And Sana, come. Where is Sana? Come forward. Pay respect to man today. Sahana is she's an NICVD Dhaka. Sahana comes.
Thank you. Nice meeting you all. Last year I did many talks with Bangladesh Dhaka doctor. Dr. Naveen, she was with us in a squad.
Okay.
तो उसने ऑनलाइन वो कोविड टाइम में ना लास्ट ईयर तो ऑल एसडीवी एपीडीए कुछ कर रहे थे तो
This is entirely an NICVD group.
ओके तो वो कार्डियोलॉजी
Dr. Manwal Islam is an NICVD professor out there. Manwal, Sardendu, and Ishrat and Sahana. And I know Sahana and Manwal in Australia for a long, long time. Maybe 10 years or more. And Manwal has spent about a month over here working with us. Very intelligent, dedicated cardiologist.
Many congenital cases come from Bangladesh to India.
so welcome.
Dr. Aziz come. He has come all the way from Maldives.
Okay.
That's what he's learning out here. Like,
And means it's pleasure actually.
and
Now
ma'am is
interacting with
always, Dr. Munish is one of those finest pediatric cardiologists, and you could see a dynamic way of teaching.
I was thinking I have cards.
I'll forward your number to all of them, like words of
Because
wisdom.
connected रहे तो अच्छा रहता है and we all have some little issues and can be sorted out on WhatsApp only now WhatsApp is something. So thank you for coming to India and sir is the link for that and thank you sir.
My pleasure. Like, I must say thanks to all of you because I've been thinking of this for last 4 years. I don't know how to do it, and many times it fizzled out completely. When I talked to Neeraj, Neeraj came over here in Delhi after meeting. I said, Neeraj, let's do it. He said, let's go it. Then immediately called me back and then he said, let's talk to Dr. Manish and let's talk to Dr. Smith. I said, I'm going to talk to them. He said, they are my seniors, I can't talk to them. I said, I'll talk to them. And when the response was immediate and we planned it so fast, like within 2 months we were able to do it.
Thank you so much, sir, and thank you so much, ma'am, for such an excellent.
And it's not a learning for you, it's a learning for me also. You know, like we do a lot of pediatric echo and like number of times we do learn so many things all the time. And learning is never ending a process.
Like every case is new actually. Means for us anything new just come on the way. So nothing is simple, straightforward.
And lot of credit goes to Dr. Parashar sir also. Like he's always instrumental all the time. Let's do something different. Let's do something different.
Ma'am, how is sir? Doctor?
You know it?
Yeah, he's been his student from Medanta.
Acha, okay, he's fine. But I have to go back to Meerut and then come back for a dinner. So Meerut दिन में 2 घंटे.
You're still staying in Meerut now. Or you have to move to Delhi?
I'm moving to actually the flat is getting ready, so daily I'm doing up and
Up and down from Meerut.
हाँ.
But that new highway is faster.
Yes.
That's what
It
takes
takes
you
like in
1 hour.
coming here morning it took 2 hours, 1 hour 50 minutes.
Yeah, which is faster, much faster
Much
than
faster. Today because there is no traffic. So go back and come back.
Chai
But
coffee
thank
कुछ
you.
हो गया?
बस सर मैं निकल जाती हूँ बस.
Driver का फिर
ड्राइवर मैं अभी इसको पूछ रही थी अगर
अमर?
बोले
अमर एक मिनट अमर साथ मैं चल रहा हूँ टेक्निकल समथिंग कॉल अमर बैग पकड़ो पहले
Ma'am, currently you are in NAC.
yes you have to match साके
Ma'am, in case any congenital cases we can discuss when we are free time.
हाँ बस you just send a leave a message accordingly we can do it.
Ma'am, if we can have your
हाँ हाँ.
yeah take it
Double
Amit is
A.
another one there he has done his DNB cardiology he is in his SAR right now
अच्छा.
yes
Double 800 216 555. ठीक है. Anytime. But we just leave a message accordingly we can discuss because phone कभी कहीं you have to
What's
हाँ ठीक है, ये पेशेंट पे बैकग्राउंड रहती है तो बात आराम से ठीक है, ओके थैंक यू वेरी मच, थैंक यू मिलते हैं फिर।
मैम मुझे पहचाना
हाँ मैं जानती हूँ, मैं मिली हूँ पहले एक्चुअली
स्पॉट्स
जैसे।
मैम जब आप एफएनबी कर रहे थे आई वाज देयर डॉक्टर आयजाज तोमर वाज देयर सो
अच्छा,
आई
अभी वो आते तो सही रहता ना आप।
हाँ मैं वो पूछने वाला था इज इन मेरिट ना हाँ तो आई बेसिकली एडेड पेमेंट कार्डियोलॉजी तो सर से कनेक्ट हुए उससे 3-4 साल से तो आई तो मैम आप मेरिट से वो करते हो जैसे डॉक्टर आयजाज तो वहीं पर है ना बहुत तो हाँ मैं अदरवाइज अच्छा यू गो शिफ्टिंग टू गो नाउ
थोड़ा सा कॉम्प्लिकेटेड सिचुएशन बनी हुई है। That only you can mix with other people.
अपने हाथ तक के लिए आराम से नाचते हैं
भाई, अब वो कहाँ है टॉर्च?
So good morning again. I hope everybody is not sleeping.
I think this talk will make them sleep.
No, they'll not, definitely not.
देखना, वो देना टॉर्च, जल भी रही है। चलो लाइट ऑफ करो, एवरीबडी इनसाइड। अच्छा ठीक है ठीक है। ठीक है, ये चलेगा फुल स्क्रीन। ये देखो ऐसा है ना,
Wine bottle.
फुल नहीं, ये अच्छा इधर से वो आता है।
डबल आ गया वो सर आपके पास होते हैं।
यहाँ डबल आया, वहाँ
हाँ,
नहीं।
सिंगल आएगा सर।
अच्छा चलो,
इसको रिकॉर्ड और ट्रांसलेट दोनों। आप करंट आ रहा है इसमें? आप करंट आ रहा है? कोई बात नहीं, पता ही होगा मशीन से प्रॉब्लम है, वो यहाँ नीचे नहीं है।
इधर कैसे लाइट कम होगी? इधर कैसे लाइट कम होगी? कहाँ से आ रही है ये लाइट? कहाँ से आ रही है ये? इसके ऊपर, स्क्रीन के ऊपर। हाँ,
कौन सी सर लाइट?
हमने कहा ये जो है इसके ऊपर, उसकी आ रही है कि किसकी? नहीं
वो तो आपकी इमेज आ रही है सर ऊपर से।
नहीं, बस ये जो अच्छा जो जैसे लाइटेड लग रहा है ये
सर ये वाला आ रहा है सर।
अच्छा चलो ठीक है ठीक है।
हाँ,
हाँ हाँ हाँ, तो बड़े दिनों बाद नजर आए ये लोग तो। इन्होंने मोर यंग, ओल्डर
सर आज तो बिल्कुल मजा आ गया।
माय गुडनेस, because both of them have stopped coming to the any sessions also.
Last 3 years we don't have managed to leave.
No, you said कि you can't get a visa or something.
No,
हाँ, ऐसा नहीं
no,
ना।
government job, no, they are
हाँ,
not permitting us going
so
abroad.
now not in government job.
We do not need any visa, but we need geo from government.
Government order. Government order.
Right now, sir, government is
Very
restricted to give
Allah,
permission to
अच्छा।
travel.
We are annoying Rakesh sir this times. They do this letter, do this letter, do this, do that, etc. Many times.
Good.
Give letter to our ministry, give letter to them, give letter to them.
चलो good.
Please sit down, we'll start. Okay, friends, let's start with, we have with us Dr. S.K. Parashar. As I introduced on the first day, the father of Indian Academy of Echo. Many of us learned echocardiography from him only. And he was the first person in India who started doing mode echocardiography to begin with, after learning his art from Italy. I'm talking of way back in 70s, early 70s, if I'm correct, early 70s. And presently, he is at Heart Center at Lajpat Nagar. He has been the past president of Cardiological Society of
Oh,
India,
thing I
as well
think.
as Indian Academy of Echo. In
चलो।
fact, Indian Academy of Echo has been created by him. That is
इससे
his
किस
child.
हाँ, ये किससे चलती है? इससे।
We have been together for more than 25 years now.
पी लिया कॉफ़ी और मंगवा दो ज़रा अच्छी गरम। हाँ
This particular program, whatever we are doing, that is his brainchild. We started with April 2000, the first training
ये
program
तो
in India.
पी लिया हमने, पी लिया। हाँ।
With just few words, let me hand over my mic to
So,
respected Dr. Parashar.
I do not know how this topic is relevant to congenital heart disease. I asked him. He said, no, please give them, please.
It's very relevant because majority of these congenital heart disease people, they present with pericardial disorders
So,
associated with it.
but
And that's why it's most
they present with a different test. So what we'll discuss, we'll only discuss some of the pericardial disorders, showing you some images or so, and whenever you feel sleepy and bored, we can stop it because it is slightly longer lecture. So before coming to the topic, I told you yesterday that your clinical examination is always very essential. And you see that, and this is why here you see the patent ductus arteriosus, large, moderate, small, silent. It depends upon your auscultation and some of the findings on a clinical examination. Now, in my about 48 years experience in echo, I can quote you numerous examples in which lack of what are the effect of this not auscultation. We had a 50-year-old lady who was continuing diagnosis as a dilated cardiomyopathy. But when at one of the review echoes we did in that lady, we found that the patient had a large patent ductus arteriosus. So from a completely non-treatable case, she became to a treatable case. Another patient with a severe pulmonary stenosis and ASD was operated, and when we were following after operation, we just by mistake I put a stethoscope and we found a harsh systolic murmur, and then we found that the patient had a small muscular defect also. So we can give you numerous examples, but all these things in this I particularly brought out this because many times you don't see such cases, because as you may miss it also, because as you know this is a young lady with mitral stenosis. You can see there is all the signs of mitral stenosis, and the mitral wall area was about 1.2 centimeters square. And you see it is again about 1.2 centimeters square. But when the Doppler was done, the mean gradient was markedly increased to 23. So though the area was 1.2, but the mean gradient was 23, and by a pressure half time the area was about 0.8 centimeters square. So that means there was a discrepancy between the anatomical area determined and the gradients and the pressure after, because in this situation it was a sort of so whenever you get a great discrepancy between area and the gradient square, one of the possibility you should think of is a subvalvular stenosis, because in a subvalvular stenosis you are measuring area at the valvular level, but on a Doppler you are measuring it at both a valvular and a distal level. And you see in this vision, you see in the distal to this mitral wall there is a marked turbulence and a narrowing here, and you see the mitral wall opening here, and you see the narrowing is there, and you give a turbulence here. So you see again, you see, so the turbulence is at a much later part also. So this gives you a diagnosis of a subvalvular apparatus. You should think when there is a lot of discrepancy between your area and the gradient. Number two, these are one of the situations where the PST plays a significant role, as in this case, and then you see the turbulence much beyond the mitral wall area. So that is keep in mind when these situations are so. So coming to and this is sometimes, because this is, I don't see much in the reports nowadays. Whenever you do a mitral stenosis, you must do we are always doing a commissures. That is a must in these cases, and there is a newer classification. When the commissures are calcified, the area is 0, point is 0. When they are non-calcified and they are partially fused, it is 1, and when they are not fused, because you are ultimately splitting the commissures in a mitral stenosis. So when they are not fused 0, partially fused, extensively fused 2. So the higher the score, the better will be the result with a balloon mitral valvotomy. So the higher the score, the greater success of the BMV. So that this is good thing and this is good thing. So any of these things can be done or so. So now we come to our topic also. This is all of you very well know the fibrous and the epicardium, so I need not go into the detailed anatomy, and which you know there is always a certain amount of fluid between the pericardial layers, and that is to prevent avoid infection, prevent friction and other things also. Now what we will be discussing today, we will start one by one only. We will give more time to constrictive pericarditis, because if you can understand this will take hardly about 5-10 minutes, nothing more. So first evaluation is clinical evaluation, clinical evaluation, clinical evaluation. That means history and physical examination. So that is a very must in these cases also. I need not go into the history also in these. And once you come to the acute pericarditis, 2 of the 4 must be present. A chest pain is sometimes relieved in a particular posture. Sometimes patients say when I sit in front, the pain is relieved. Sometimes he says when I'm sitting on one side, the pain is relieved. So the chest pain on a relieved in particular position and a pericardial rub. Sometimes you can hear it better when the patient is bent forward. A sequential ECG changes are very uncommon, and a new or increasing pericardial effusion for next 4 to, that means the presence of a chest pain, pericardial rub, this is uncommon, and the presence of pericardial effusion. That is why according to the current guidelines of the American Society of this American College of Cardiology and ESC, all patients should be given a treatment of colchicine plus aspirin when you have an acute pericarditis. The studies have shown that they must reduce the clinical course of the disease. They prevent the development of a recurrent pericarditis. You become symptom free much earlier. So now colchicine has been recommended as a usual treatment in case of an acute pericarditis. Then these are the ECG changes. Normally what we see, we either see this stage or at this stage and this way. So these are the various stages. First of all, there is an elevation of the ST segment, and there is a depression. So these are according to the stage wise the various changes, and either we see this or we see this. But this can also be present in the early stages or so. Then what is recurrent pericarditis is a very well known condition. A recurrence after a symptomatic period of 4 to 6 weeks. That means a patient had a real episode of pericarditis. He remains asymptomatic for 4 to 6 weeks and again develops a pericardial symptom. So that is known as a recurrent pericarditis, and it is usually present in about high as about 30% of cases. So recurrent pericarditis is given a lot of importance. The symptoms are like an acute pericarditis, what we discussed in the previous slide, and there is a symptom-free period or a symptom-free period from this or a new pericardial effusion. So again the recommendation is colchicine 1 milligram BD on day 1, then 0.5 milligram BD for about 3 to 6 months, and the patient is less than 70 kg, 0.5 kg. This is to be combined with aspirin or so. So combination of colchicine and aspirin much reduces the incidence and the symptom-free period. So don't forget now, because we are not used to giving colchicine, but it is now recommended by the whole of the American Society. So this is known as a recurrent pericarditis. Now we come to pericardial effusion. Now as you know, it is clinically like an echo-free space throughout the cardiac cycle. Number 1, always see multiple scan planes. Number 2, always see the reduced gain. When you see a reduced gain, you only want to see the posterior structures, that is the pericardium. And then sometimes you may get this is sometimes misused as a case of a pericardial effusion, but you see here, we'll show you this, because what should be a diastolic septum? Number 1, we see a systolic separation, diastolic separation, quantitation, and we can see whether it is global or localized, whether semi-quantitative, what is the fluid appearance, and ELISA variant. All patients of pericardial effusion should be evaluated for a hemodynamic compromise, as because they may produce certain changes. So now you see systolic, many of these cases are diagnosed as a pericardial effusion. You see here, as I said, the first sign of a pericardial effusion is a diastolic echo-free space. So this is because of the normal fluid which is present in the pericardium, which vary from 30, 40, something like this. So I usually call it as a physiological effusion, and sometimes many of the radiologists, when they do a subcostal, they report a minimum pericardial effusion present, but this is more of a physiological, and this you see, we have decreased the gains to meet this all decreased. Now you see, the separation is only in systole and not in diastole. There is nothing in diastole, only in systolic separation, and after reducing the gain. So this is more of a physiological and should not be you can write this a minimal physiological effusion but not otherwise. Clear? Any doubt you go on asking, because it is an interactive session. So you are clear about this physiological thing, and only because it's only in systole. But what I said is, there should be a now here you see it should be present throughout the cardiac cycle, both in systole and diastole, and here you see it is present in systole and diastole also. So this is a pericardial effusion which is not a physiological one, because it is present throughout the cardiac cycle, and you see both in systole and in diastole. So coming to the quantitation, now it is depending upon it is semi-quantitation depending on the distribution of fluid and the extent of the diastolic echo free space. Remember, diastolic echo free space, not a systolic echo free space, because the pericardial effusion in diastole is more important. So because many persons are just measuring systole, but it is a diastolic. So the more it is distributed all over, the larger the effusion. So this has usually been, as I told you, this is a trivial. Small is usually less than 10 millimeters, which is usually posterior. This you see, this is usually a posterior pericardial effusion, small, because now here you see don't measure in systole, measure in diastole. So it is usually less than 10. So that is a moderate is usually, this contains less than about 100 or so, and moderate is when it is 10 to 20, large when it is more than 20 and more circumferential, and very large when it is more than 25. So just remember 10, 20, 25, that will give you an idea. Now you see, this is we call as this is a moderate pericardial effusion, definitely. Now why we call it a Why syndrome? We believe in a lot of Why syndrome, that once you get an unexpected finding, it is why, then you have to look for it. For example, we have got cases of mitral stenosis. The patient has got an LVH. Patient is not hypertensive. Why there is LVH? You have to explain it. So that is known as the Why syndrome, and then you see for any aortic valve disease also. So here the Why syndrome was that why should the RV be enlarged so much in pericardial effusion, correct? Then you see this RV enlargement, and then why should there be a flattening of the interventricular septum because of a volume or a overload or so you see. So pericardial effusion is there, but why? So that is a Why syndrome, and then we went further evaluating it, and then we found that the patient has an Ebstein's anomaly. You see, so that was the reason. That was about a 55, 60-year-old lady. So that explained the symptoms, the signs which we found other. So the Why syndrome will be very helpful, and you see there is a large atrialized right ventricle, there is a large RA, marked shifting, a sort of a sail-like anterior leaflet, and marked shifting of the septal leaflet of this. So that was the cause of this thing. And this is of course a large pericardial effusion. It is more than 20 millimeters. So you have seen small, you have seen moderate, you have seen a large pericardial effusion. So you can either do an M mode or take a M mode across it, and during diastole measure the diastolic echo free space, and you can classify according to how much is present. Now sometimes many of you don't auscultate. Now this patient was referred for urgent pericardial tapping, and possibly the auscultation was not done. When the patient came to us, we found that this fluid is behind the aorta, so and it is extending behind the left atrium. So any fluid which is behind the aorta is a pleural effusion. So now if they had auscultated the patient nicely, they would have found the signs of a large pleural effusion. So remember, whenever you get an echo free space, and sometimes you can see it is extending beyond the left atrium and it is behind this. So you see, this is the left atrium, this is the descending aorta, and this is the fluid. So this is a pleural effusion. Always make a mental idea of this. Same thing you can see. So this is a descending aorta. Anterior to it is pericardial effusion. Posterior to it is a pleural effusion. Again you see, You see again this thing. So again you see it is posterior, so it is a pericardial pleural, and you see here and you see here it is anterior to the to the pericardial, this anterior descending aorta, so that is a pericardial effusion, and you see doesn't go significantly behind the left atrium. So remember the descending aorta. And this is quantitation, you can see. You see, here it is present all over. So here you can see it is present all over, behind it is anterior, but you see whole of this is containing the pleural pericardial effusion. So even if suppose this is less than 20 or so, but still if you see this, you can always say that it is a large pericardial effusion. So just see the distribution and the quantity. And you can sometimes see, now this is a pericardial effusion, this is, you see. Now this tells us that it is a fibrin deposit, it is not a simple pericardial effusion. It is either a marked exudative thing. So by seeing the structures around the pericardium, you can see that it is a fibrinous material or more of a pyo or a tuberculosis. Now we come to the most important topic. If you are sleeping, try to get up. If you want to take a cup of tea, because this is a very important topic. And once you remember this, you will always remember pericardial tamponade. So we'll discuss something about the constrictive pericarditis. Now, what is the significance? That it is a reversible cause of a diastolic heart failure. So it is very important to recognize it, because you can treat it. Otherwise, many of these cases are untreatable, and it can be curable or reversed with anti-inflammatory therapy. Symptoms are very variable. There is a large differential diagnosis, and 10 to 15% of cases missed if no index of suspicion. We might have missed almost 10 to 50% cases ourselves also, when it was not. But now we see one or two signs, and those one or two signs give us a hint that please look for a constrictive pericarditis. So that is why a lot of cases have been sent for we have got one case sent for a liver transplantation, but during a pre-operative evaluation by echo, it was found to be a case of a constrictive pericarditis. So it is many of these cases are missed. So by history, unexplained dyspnea, it may or may not be any case of an unexplained dyspnea. Think of constrictive pericarditis, heart failure with normal ejection fraction, and systemic congestion. Why systemic congestion? We let you know. Unexplained edema, ascites, RAGE, GVP, and all that. These patients who these patients who have undergone liver biopsy and many other things. Patients of tuberculosis, post-cardiac surgery, radiation with signs of right heart failure. Why should a patient of tuberculosis or post-cardiac surgery undergo a right heart failure? And then many other conditions that most skilled diagnosticians can be confused. So just consider these few possibilities in these cases. And echo plays a very significant role. Now what is this is always challenging. Everybody tries to measure a pericardial thickness also, but remember in a transthoracic echo, very less reliable, and that to again measure in diastole. They say about more than 2 millimeters, but very difficult to measure sometimes. And in the TEE, it is more than 3 millimeters, and then CT more than 4 millimeters. So remember 2, 3, 4. And so that is, and the CT, and they are more sensitive. So when you are asked the thickness of the pericardium, say 2 to 4 millimeters, because 2 millimeters by transthoracic, 3 by transesophageal, 4 by CT. This is the usual thickness of the pericardium. Now why a diagnostic enigma? Now think the enigma. Now, what is the basic if you remember the basic pathophysiology, you'll understand the various other factors on this. Now, there got in constrictive pericarditis, there is a thick, scarred, calcified pericardium or not? That is constriction. At it is known as constricting. It is constricting the heart. So it is a very thick, scarred, or may not be calcified pericardium, which is constricting the heart. So when it is constricting the heart, ventricle loses its distensibility. After an initial feeling, when the ventricle tries to relax, it is suddenly stopped because it cannot expand because of the marked constriction. There is early diastolic feeling, then it can get stopped also. So when this occurs, the venous return is hampered, because when the ventricle cannot relax, your venous return will be hampered. So there will be an increased filling pressure in all chambers. When you just remember, increase the diastolic pressures in all chambers, because you may be confused with filling pressures also. Increase diastolic, and that is why when you do a cardiac catheterization, you find that there is a diastolic pressure is present in all the 4 chambers or so. So because of the decreased filling, when the filling is decreased, automatically the pressure will increase, because they still want to fill the ventricles, already want. So there is a increase in the pressures. Now what happens that when there is a pressure increase in all the chambers, on the left side what happens? There is an increased left atrial pressure, correct? A left atrial pressure will lead to an increased pulmonary venous pressure. It will lead to pulmonary congestion, lead to a dyspnea and cough. So the reason for a dyspnea and the cough is the presence of increased pressure in the left atrium. On the right side, when there is the right atrial pressure is increased, this leads to rage, JVP, edema, ascites or so. So many of these patients can present with this, or this depending upon the symptoms or so, and this is because of increased pressure in all the chambers or so. Any doubt? Please go on asking. So the diagnosis, clinical suspicion, still 2D echo and Doppler is the prime diagnostic, but CT MRI can also help in early diagnosis or so. This may be slightly difficult for you, so I will just tell you now. There are 2 basic abnormalities you must demonstrate in case of a constrictive pericarditis. I will explain them. One is a exaggerated ventricular interdependence, and one is an increased intrathoracic pressure, cardiac pressure, intrathoracic pressure dissociation, and both of them are related to each other. Now, in a constrictive pericarditis, there is a fixed cardiac volume. Let us give an example. Okay, so these, and you have to show these 2 things. So you see, now I'll just remember, suppose it is because of a fixed cardiac volume, suppose the RV has got 50 ml, LV has got 50 ml, and that 100 ml is the maximum that can be kept in the cardiac chamber because of a fixed volume of a constriction. Now, if the RV becomes 60, the LV becomes 40, because they have to maintain up to 100. If the LV becomes 65, RV has to come to 35. So there is a alteration in volume must by necessity reflected by a change in volume in the chamber. So don't go into all the details, but so there is a variation in filling between the RV and LV. Suppose LV filling is increased, is reduced, the RV filling is increased, because they have to maintain a balance, correct? Suppose the RV filling is reduced, LV filling is increased. So this is known as a ventricular interdependence. They are interdependent on each other also. Jago. Any doubt about this? So this will show you also. See this. During inspiration, there is more of the filling of RV, correct? That normally occurs. And LV filling becomes less. So the septum is shifted to the LV side, because the RV is more and septum is between RV and LV, it is shifting to this side. During expiration, the LV filling is more. That is a normal sequence. And when the RV filling is large, this becomes small. And the septum now shifts over the RV. So this is ventricular interdependence. That means they are dependent on each other. If this volume increases, this decreases. Here this increases, this decreases, and consequently the septum moves on the other side. So this is known as an interdependence. Now, dissociation of intrathoracic and intracardiac pressure. Don't go with this confusing heading. I'll show you this. Now you see, in a normal person during inspiration there is a decrease in the intrathoracic pressure. So that means that because the pulmonary vein is an intrathoracic structure, so its pressure falls. When its pressure falls, all the other in a normal individual, all the other pressures fall. So there is a continued flow between pulmonary vein, left atrium and the left, because you know pulmonary vein drain into LA, L into LV. So there is a proportionately decrease of all the vessels and there is no problem. What happens in a constriction? Heart is isolated because it is fixed, it is built by a thick calcified pericardium. So what happens that, as I told you, that the filling pressure is increased. All the pressures are increased in constrictive pericarditis, including the left atrium. Now when the left atrial pulmonary venous pressure is decreased, but the LA pressure is not, it is high. So there is a decreased gradient between LA and PV and LA. Because pulmonary vein pressure falls, LA remains the same because it is high pressure because of constriction. So there is a decreased flow from pulmonary vein to left atrium. So there is a decreased flow from pulmonary vein to LA to LV. So it decreases the LV filling, correct? So because the left sided pressures are increased, pulmonary venous pressure is less. So the less blood goes from pulmonary vein to LA, correct? So the less blood goes from LA to LV. So the same thing, as a result of it, there is a decreased LV filling. When the less blood is going into the LV, it is a decreased LV filling. So there is an increased RV filling, and this leads to a respiratory variation. This is because of a interdependence, correct? And this leads to some respiratory variation, which I'll show you just now. For example, here you see, this is inspiration. In inspiration, there is a decrease in the intrathoracic pressure. There is more flow into the right ventricle as compared to the from the LA to RA to RB, and less on the right side, left side. In expiration, the reverse occurs because now the more filling occurs in this and less filling occurs this. So this is all when the thick arrows show more flow, the thick arrows show less flow. So this is the reason that in inspiration, because more of the RV is filled up, LV is filled less, correct? And in expiration, more of the LV is filled up, RV filling less, that we showed you in the previous slide. So what is this, what happens now? So now let us see this patient first. A 35-year-old male, feeling of weakness, lethargy, cough and dyspnea, same thing about what we told you, vague GI symptoms, and clinically suffused with edema, feet, ascites present, liver 2 centimeters palpable, and then as such he was referred to a gastroenterologist. The gastroenterology started investigating for a primary liver disease, but luckily the patient developed a marked tachycardia and he was referred to us. Now you see here, you see the heart rate about 170, but there is a marked, we will come to this again, there is a marked jerky motion of the interventricular septum, which will come to it later on also. And when we did an M mode of the study, we will come to this slide again, it showed a classical sign of a constrictive pericarditis. We will come to this slide again to explain to you further. So that is what this showed you, why this sign is there, and the most important sign, and why this gave us a diagnosis of constriction, I will let you know just now. So you have to diagnose by any of these imaging, these two things of a interdependence and respiratory variation in both by any of these. And there are very many signs described, but the most important ones are known as a septal bounce, known as a thickening, singing, dilated IVC, and many other signs are there. But some of the important ones are, you see, so you see, this is, can you see a jerky motion known as a septal diastolic shudder? So why it happens? Because of because microsecond this ventricular interdependence. RV is increased, septum is moved to the left side. LV is increased, septum is moved to the right side. So this rapid movement of the septum on a microsecond level produces this shudder also. You see it is going toward the LV, going toward the RV, and if you see correctly, it is found in about 96% of cases. Just focus on this, that there is a shudder like this or thing. Similarly, whether you take any view, you see here, short axis view, you can see a shudder of the interventricular septum again here. So you can see this rapid jerky motion, and this is you can see in all the cases you can see. Then IVC, and it is this IVC is enlarged because of increased RA pressure. As you know, when you have been told about pulmonary hypertension or diastole, when there is increased RA pressure which occurs here, any structure which is now IVC is draining into RA, the RA pressure is high. So any structure which is draining into high pressure chamber enlarges in size, just to fill up also. For example, you get RV, RA enlargement in pulmonary stenosis, pulmonary hypertension because of this. So it is believed that a absence of a IVC dilatation without dialysis should question the diagnosis. So once we are suspecting this constrictive pericarditis, we just see the subcostal view. If subcostal view does not show IVC dilatation and patient is not on any diuretic, we question the diagnosis of a constrictive pericarditis. So you can here you see this, and this is known as a spontaneous contrast echo because of the plethoric, and IVC shows a large and a poor collapse. So these are the important signs of these. So these are 5 signs. We'll just show you just 5 principal variations of a diagnosis of constrictive pericarditis. One is a ventricular septal defect, a shift. Now we showed you this slide. Now this is a respirometer. The up limb is the inspiration and this is the expiration. As I told you, during inspiration, the RV, you can see during inspiration, RV size increases, correct? And septum is pushed toward the posterior wall, pushed back into the LV. And this is the cause for what is known as a pulsus paradoxus, or in this situation because there is a fall of the blood pressure or decreased cardiac output. During expiration, you see now what happens. The septum is pushed toward the right ventricle because the LV size is increased. You just see very carefully, this is the RV coming. During inspiration, the RV increases because of increased filling, pushes the septum posteriorly towards LV. During expiration, because of the more filling of the left ventricle, the septum is now shifted toward this. So this is a first clue of a diagnosis and sent to about 93% of cases, and this is known as a ventricular interdependence. Any doubt about this slide? Then the same thing, as I told you, this dissociation between intrathoracic and intracardiac pressure is variation in the mitral E velocity. Now you see, during inspiration there is more filling of the tricuspid valve and right ventricle. So there is a proportionately less filling of the left heart, correct? Can you see this? Because this again interdependence and this thing and in the respiratory variations also. So during inspiration the tricuspid flow increases, during expiration it decreases. The reverse happens in mitral valve. During inspiration it decreases because here now this is again the thing, more RV, less LV. At expiration it increases. Any doubt? Why this happens? Is a combination, as I told you, ventricular interdependence and the intrathoracic and the pressures also. So you see, now you see this is inspiration, expiration. The first beat in inspiration you can see the velocity significantly increased, and the first beat after expiration the velocity significantly increased. Can you see this? Everywhere. So the E velocity in expiration minus E inspiration divided by E expiration into 100 is the mitral wall variation, which should be in a normal individual is less than 15%, maybe 10%, 12%, but here it is more than about 30%. So this is known as a respiratory variation. Now number one, it should be on a pulse Doppler.
Sir, inspiration and respirometer, inspiration and expiration is point.
So this is inspiration, up solely inspiration, correct? And you see, the upstroke is inspiration and the downstroke is expiration. So you see, so now two things. Number one, use a pulse Doppler, and number two, reduce the speed, because you find more complexes. If you have hardly one or two complexes, then you don't know how to measure. It should be consistently present. Reduce the speed of the recording so that you can see more of this, and use a pulse Doppler. And you see it is present, it is the first beat after expiration, and it is first beat after inspiration, expiration, the same thing present, and we see we have reduced the speed, and you see it is about 30%, which is more than 25% is supposed to be good, more diagnostic or so, and this can be because this is the formula to correct it also. And you see, now if you don't have a respirometer, so what will you do?
Highest and lowest.
Yeah, remember, if you don't have a respirometer, the lowest velocity is always in inspiration. You take a long recording and you see the lowest velocity is always in inspiration. Gone are the days when we used to put our hand on the abdomen or see, but you record and the lowest velocity is in inspiration, and the next will be automatically expiration. And now see, this same patient after treatment from 30% came down to 10%. This respiratory variation has become much less also.
This is pericarditis.
Sure, it was very extensive case, huh? Because once there is a calcified pericardium, then these colchicine also don't help. The same thing again, tricuspid wall you see. You see again during inspiration the velocity of the tricuspid increases, and during expiration the first beat it decreases. It is consistently present in all the cases you can see. So that you will take more of a complexes, and here it is almost more than 40%. And this it should vary from 40 to 60% or so, and this is because of an increased filling during inspiration and decreased filling during expiration. Clear or not? Because this is all. And of course, it can be present in absent about 30% of cases. In these cases, there are very other causes, constrictive pericarditis.
Atrial fibrillation.
So the atrial fibrillation is the same thing. We'll come to it. When we have finished all the signs, then we'll come to it, to the atrial fibrillation. Now, then you see this mitral annulus velocity. So you have seen this, you have seen this, correct? So that's the mitral annular velocity you see. Now you see what is the, now you see what happens. Now this is a constrictive, what happens in constrictive pericarditis, most of the filling occurs in early diastole. The tissue velocity imaging records the velocity at the annular level, correct? If the low velocity flow occurs at the annular level. So the more the excessive movement of the annulus, the more will be the velocity recorded. So what happens in these cases, because of the most of the filling occurs in early diastole, so there is a excessive motion of the, this is in early diastole, and then it is suddenly stopped because of a constriction. So that means if you do a tissue velocity here, it will be significantly increased. Now we see three things in this. Exaggerated longitudinal velocity when it is more than almost preserved or more than 9 centimeters per second. Annulus paradoxus, annulus reversus. There are three things you see in a tissue Doppler imaging which will demonstrate to you. So first thing you see is that you see here the early diastolic velocity goes up to almost 20 centimeters per second. So despite the disease, the early diastolic velocity is significantly increased, correct? You can see this. It has been put at again a pulse Doppler put at the medial annulus and see a tall B wave going up to 20 much more than 9 centimeters per second. Now, ratio of the mitral to the lateral velocity. Now, normally the lateral annulus velocity is about 25% more than the medial velocity, because it is a free LV wall, and this right vent and the medial velocity is a common between RV and RV, and there is an annulus also. So, but so the reversal of what happens here. Now see, this is known as annulus reversus. Why? You see on the medial annulus about 18 millicentimeters. On a lateral side it is only about 12 centimeters, because the same fibrotic process is according to the ventricular free wall. So this constriction process is according to the free wall, so it reduces the velocity of this thing. So this is known as annulus reverses, and it is here about 1.5:1, because this is normally this should be much more, and this is because of the perimyocardial adhesions and fibrotic according to ventricular free wall. When they are more in the anterior free wall, the velocity will be decreased. So it is 1.5, and the same patient after surgery it has come to 1.1:1. So that means when they have stripped the pericardium, so this you see, this is the medial annulus, this is the lateral annulus, the velocity is now increased in these cases. So this is known as an annulus reversus. From a strain imaging, it is known as a strain reversus. The same thing, it is known as strain reversus. Now, then what is pulsus paradoxus? This is annulus paradoxus. Now you know, in a diastolic heart failure, pure diastolic heart failure, it is because of two things: relaxation abnormality and a compliance abnormality. So at in the early stage there is only a relaxation abnormality, and the relaxation abnormality is manifested by E prime rate, E prime, that is the tissue Doppler early diastolic velocity. As the disease advances, the LA pressure also increases in next stage because of a decreased compliance. Increased LA pressure is manifested by tall E wave. So in a pure diastolic heart failure, the E wave increases, and this E dash progressively decreases, so the E oblique E increases as the heart failure increases. You understood why? The higher the LA pressure, the higher the driving pressure between LA and LV, the higher the mitral wall velocity, and this, so the E oblique E prime ratio is there. And in congestive pericarditis, it is not at the level of, there is no relaxation abnormality and no myocardial abnormality unless it is a late stage or so. So what happens now, you see here, in a heart failure, as the disease progresses, the E oblique E prime ratio goes on increasing. In a constrictive pericarditis, the more the constriction, the E velocity more further increases, E prime. The greater the longitudinal motion, and E oblique E prime goes on decreasing. So this is known as a annulus paradoxus, that it is there, that the ratio goes on decreasing as the LV filling pressure goes on decreasing. Now you see annulus paradoxus, why? And you see it is, although the constrictive pericarditis is there, but the ratio is only 5.5:1, while beyond 15 it is more important, indicating of an increased left ventricular filling pressure. So we have mentioned most of them, and here you see the expiratory, again this expiratory, and when you take a hepatic vein, there is an increased expiratory reversal. You see, this is the expiratory reversal of the hepatic vein, and you can, this is of course too much for you or so. And you see, the 1, 3, 5 is more important. One is septal shift, 3 medial velocity, and this hepatic vein. The more the combination, the more is the severity of the diagnostic. 1, 3, 5, remember. So there are certain important variants. One is known as the transient constrictive pericarditis, about 7 to 10%, and constrictive pericarditis with normal pericardial thickness about 15 to 18%, reported from Mayo Clinic. Transient it is a well recognized condition, 7 to 10%. Any condition leading to chronic constrictive pericarditis except radiation pericarditis. In a foreign country, the most common cause of a constrictive pericarditis is a surgery or a radiation, besides other of course viral and the thing. Now these patients have got an initial acute pericarditis. If not given colchicine, they may go into a constrictive physiology, but this is a constrictive physiology, not a pericarditis, and they normalize after about 3 months or so, and this is they present with edema, dyspnea and everything, and it is because of some fibrin deposit and inflammation, but not a sort of a calcification. They usually reverse in 2 to 3 months, and medical treatment for 3 months and observe. So that whenever you get a patient of a constrictive physiology, patient is not symptomatic, try to give him anti-inflammatory treatment with colchicine for about 2-3 months, and then observe again. They reverse, but only the worsening of symptoms or clinical disease, then you can think of surgery. But there is a well-known condition of a transient constrictive pericarditis because of edema and a fibrin deposition. And this of course has been reported there. It is clinically same as thickened pericardium. Pericardectomy is still very effective besides normal pericardial thickness, and they say do not deny surgery in patients with normal pericardial thickness. The constriction can occur in a scarred fibrous pericardium of normal thickness, which can be mild or focused. So that occurs only the later stage when it comes also. Now see, again a Weiss syndrome. This patient had a mitral valve replacement 3 years back. He came with increasing dyspnea, fatigability and distension of abdomen for 2 months. Clinically suffused face, JVP raised, clicks normal, and he had a signs of a right heart failure. And you see, this is the LAs and large, and this is a mitral prosthesis because all of the signs of a or was present or so. And so it was a Weiss syndrome. Now normally what happens, first we will come to this slide. Say normally every prosthetic valve is a stenotic valve, correct? Mildly stenotic valve. And one of the findings in a stenotic valve is that it is significant, the pressure of time is significantly increased, because like any mitral stenosis, it is always increased, correct? About 207, because it is a inherently stenotic valve. So but in this case, when we did this, we found that two things, that the deceleration time was only 142. EA ratio was 2.7, indicating more of a restrictive physiology or otherwise, and you see there was some respiratory variation present. So the only this mitral Doppler gave us a hint that we are not dealing with a simple right ventricle a mitral prosthesis, but is a very different type of this. And again you see this again, and again you see my LV is on the right side, left side. I always told you. LV, RV. This is the mitral. Because I keep LV on the left side.
In case of mitral valve replacement, E by A ratio,
No, E or E prime is not applicable in these cases. It is not. I have not mentioned about E oblique E prime still. I mentioned E or A. I have not mentioned E oblique prime. You see this. I have not mentioned that because the E oblique E is not meant for a prosthetic valve, mitral valve surgery, severe mitral regurgitation, many other situations also. So you see this is an entirely different pattern of this, and you see this is the IVC is enlarged, this is a decreased collapse. So that gave us a further diagnostic hint, and there was a hepatic vein, a expiratory reversal. So, and you see, despite the TDI being is not applicable in case of a prosthetic valve, still you see in this case it was still about 9 centimeters per second. Normally it would have been 4, 5 or something like this, but it was still about a 9. So that is why we don't calculate E oblique E prime ratio in these cases. But he wanted to say despite so much of problem, it was still 9 centimeters. So that means in a prosthetic valve, that is why post-surgical is very common cause in a Western country. Respiratory variation in mitral velocity was present. That decetta was shorter than expected, and it was like a restrictive pattern. IVC changes, positive hepatic Doppler, and TDA non-contributory, but still it was about 8 to 9 centimeters per second. And this I already told you. This again, so that means remember, a history is very important. A history of any surgery, any other surgery, tuberculosis, and all this important. Physical examination, and then a presence of it to strain imaging and various invasive studies or advanced echocardiography. And if you want to go only consider echocardiography, then remember whether they are respiratory dependent or respiratory independent. That is a revision. A respiratory dependent, like a 2D findings in the ventricular septal defect. Correct? Have you seen ventricular septal defect during inspiration and expiration? The first slide. Or Doppler findings, which can be seen either a mitral inflow pattern, tricuspid, and hepatic vein. They are all respiratory dependent, where we kept a sort of a respirometer, and then respiratory independent is various 2D findings like here, Doppler findings in annulus reversus paradoxus, and some of the strain imaging. So remember, just make a note with you, respiratory dependent, respiratory independent, and you will not miss the findings in these cases. So now we'll take hardly 5 minutes because the same thing, it is a life-threatening condition. It depends upon the volume and the rate of fluid accumulation. Remember, following, suppose that you have done an angioplasty or surgery, the patient suddenly goes into hemodynamic shock or so, and the patient does not have a significant pericardial effusion. And some features may be similar to large effusion also. And remember that this thing, that now whenever there is a pericardial effusion occurs, the pericardium stretches. I am not talking about a constrictive pericardium, now it is a tamponade. So that in some cases when there is a rapid accumulation of fluid, so the rate is rapid, so there is a rapid increase in the intrapericardial pressure. But if it is gradual increase, then because of a compliant pericardium, it stretches itself and the volume increases later on or so. So this may be rapid rate and the volume independent also. Here the rate is increased, the volume is less, here the volume is more and the rate is gradually reduced. So the same thing, we need not tell you about, the same thing was present what I told you, that there is a compression by a cardiac chamber by a tense pericardial effusion. There it was thick pericardium, but here it is a tense pericardial effusion. And first of all, the low pressure chambers, because what is cardiac tamponade, the intracardiac pressure, intrapericardial pressure is more than the intracardiac pressure because of the rapid increase in pressure in the pericardial membrane. So that is more, and when it goes beyond the intracardiac pressure also, then there is a decrease of a fluid coming to the RA, RV, and then there is a hypotension also. So the compressive effect of a chamber occurs in a cardiac cycle when its pressure is lowest. We will show you just now. The same thing what we have discussed, we need not show you again interdependence with increase. The same thing what we have told you, intrathoracic pressure, same thing again. So the diagnosis is presence of varying degrees of effusion and reciprocal changes in ventricular volume. Now you see, this was a constrictive pericarditis, correct? In which you see that there was a inspiratory increase and now, but here there is no pericardial effusion, but in the constrictive pericarditis, again the same thing. During inspiration, the RV size increases, septum is pushed posteriorly. During expiration, the LV increases and the RV decreases, but there is a significant pericardial effusion. You see, so that is more in favor of a cardiac tamponade because of these hemodynamic changes. Same thing you can see always, and this is, so this is ventricular interdependence. And number 2 is enlarged inferior vena cava, you see. Again the same thing, almost positive in 92% of cases. Abscess without diuresis, question the diagnosis. The same, this is a different case, you see the same thing.
What does this mean, absence without diuresis?
Say sometimes there is something known as a low pressure tamponade. Once you are giving a patient a lot of diuretics or so, it decreases the RA pressure and it depletes the blood volume, and that is why they get a low pressure symptoms also. Then RV diastolic collapse. Now why it occurs? The intrapericardial pressure is more than the intracardiac pressure. In a right ventricular, the early, and it occurs when there is a ventricle at the lowest pressure. The RV pressure is lowest in early diastole. So in early diastole, there is a lower pressure and there is an RV diastolic collapse, and then in the left side it is late diastolic RV inversion. We will show you just now. Now you see a large pericardial field, you see this is the RV diastolic collapse. It may not be seen when there is a marked RVH present with an increased RV pressure. When there is increased RV pressure, then the intrapericardial pressure does not go more than this. So this should not be present in the case of significant RVH or a pulmonary stenosis, other things. So see, although you see this is the normal, this is the same patient, you see there is no collapse here, but you see, can you see this collapse now? This is the, and you see more after the T wave, it is the diastole, so this is this. If you don't have an ECG, you see the mitral leaflets are open. Mitral leaflets are open in diastole, and you see this collapse. And sometimes you are lucky, you can take an M mode across it, and you see this is diastolic collapse. And this is systole, this is diastolic after this, and you see this collapse, and this will disappear once you have removed the fluid. Similarly, it is not that it is always the thing of, now you see this was the patient of an amyloid or so, you can see this RV collapse, but there were no signs of tamponade. So if you see any of these signs, see for all other signs of tamponade. You see this occurs when the mitral valve opens and there is a small pericardial effusion, but there was no sign of a tamponade, but you can see this diastolic collapse. Again you see, and you see this is again you see a right atrial collapse, correct? Yes, so in fact you can see a RV collapse also, RA you see. So it should be present, if it is present for more than 1/3 of systole. So sometimes you can take it with an M mode also. The more prolonged it is, the more severe and more diagnostic thing is there. So this is LV, RV, RA, and this is the whole fluid all over the present, and you can see a marked collapse of this RA. Now similarly again you see another, now see, so although show the diastolic collapse, and you see this is the right atrium. Now the right atrium is a very thin flexible structure. So sometimes during systole, the part of it tends to show this motion. So this motion is not present in late diastole, not present in most of the systole. So this is sort of a normal variant because of a thin and flexible right atrial wall. Well, because in here you have seen and no other signs of tamponade were present, so you can always ignore it also. Another patient you can see. So whenever you see this, don't get confused, see all other signs, see the IVC, see the respiratory variation, other things also, and you can get the same thing you can see. So the same thing you can see because the two mechanisms are the same. You can see the mitral valve changes velocity, tricuspid valve changes velocity, same thing are there because of the hemodynamics is same, because there it was constriction and here it was a tense pericardial effusion which is producing a compression on the heart, as the basic mechanism is the same. So clinical pericardial effusion, Sungi IVC changes, Doppler parameter same what we have discussed in constriction, RA collapse and RV diastolic collapse. So always do a good clinical evaluation, correlate clinical and echo findings, always keep White syndrome in mind, always do a full echo evaluation, scan all views, semi-quantitative of fusion, a large peak and mimic tamponade, evaluation in absence of a respirometer. And when you said atrial fibrillation, in atrial fibrillation again the same thing, because there is a sometimes what you can do, if you take a long step, there is bound to be some time when the heart rate becomes less and a better image is obtained. Or you can say the same, the lowest one is that velocity. Then expiratory hepatic vein reversal will be present despite the presence of this. So this is again so actually this was discussed by Dr. Rakesh Gupta, that all of you are interested in echo can buy this IAE textbook contributed by many of the authors also. Thank you. I'm sure you must be tired by now. So
Which is the most specific sign for cardiac tamponade, RA diastolic collapse or RV diastolic?
say RV, they have got limitations. For example, if the RA diastolic collapse is for a very short period, it becomes less diagnostic. But if it goes up to 1/3 of systole, then it is more diagnostic. And RV diastolic collapse, again, if there is no single sign is diagnostic. So you have to take a combination of all these also. So RV diastolic collapse is also good. Go to and see the RV OT, both of them will see, and every patient will not show all the signs also. So that is why sometimes we take an M mode of the RA collapse and see how much time it takes for this. The more it takes, essentially, the more diagnostic it is. But RV is also good. Just see for all these cases also.
If you happen to find RA systolic collapse, that is more diagnostic. RA diastolic collapse will always be there. If you happen to find RA systolic collapse, that will be more appropriate.
Now, because as left-sided structures have got a thick walls, they are high pressure chambers. So the left-sided collapse are much less as compared to right-sided.
So regarding constrictive pericarditis, CT versus MRI, cardiac CT versus MRI.
Say normally you get a CT done. Say because all hemodynamics is seen by the echo also. All hemodynamics, the thickness sometimes can better see the CT.
Sometimes partial signs of cardiac tamponade are there, impending cardiac tamponade.
Say tamponade can be acute, subacute, and even low pressure tamponade. So the impending tamponade sometimes can be confused with a large pericardial effusion. But if you see that the various signs are present, then you can always say they suggested a tapping at the, in any case they have got a large pericardial effusion or so. So impending is there, either once you write a report, then you have to write what is the finding also. So if you find many of the signs of there, for example, IVCs and large, forget about respiratory variation of the mitral tricuspid hepatitis, then you can always say that a large pericardial effusion with an impending tamponade also, so that they can do an immediate thing also.
What do you mean by impending tamponade? First of all, you should be aware of what do you mean by impending tamponade?
Impending means that the patient is hemodynamically stable at this point of time and can impend.
No, if he is hemodynamic stable, then why you say impending?
What do you mean exactly? That's what I'm trying to understand. Even I could understand what you want to say.
So you see the backstride also. So
Pericardial effusion is there. We are getting the signs of partial signs of
What do you mean by partial signs?
like
Respiratory variation,
respiratory
dilated IVC, but you can't see the collapse of either RA, RV, LA, LE. LA does not collapse, LE. So if you can't see those signs and large pericardial effusion is present and respiratory variations are present, possibly that patient is in tamponade. That's what sir is trying to say. And when you have a RA systolic collapse and RA diastolic collapse contributing to more than 1/3 of a cardiac cycle, 1/3 of that echo cycle, then possibly tamponade is different.
and if you see one of my slides, I said a large pericardial effusion can mimic tamponade. If you one of the slides I said large pericardial effusion can mimic also, and that is why I say in every case of a pericardial effusion, you must take a hemodynamic parameters, every case.
And sir was very specific in certain, Dr. Parsha sir, his mode is excellent. And even I have used number of times when my eyes cannot see my systolic diastolic collapse, when I put a cursor, that cursor really tells you whether systolic or diastolic collapse. So adjust your image in such a fashion that your mode cuts across that particular collapse.
In this case, if the patient is hemodynamically stable, like we are getting features of cardiac tamponade, we need to put the patient on IV fluid first, and then
So I told you that if your patient is the signs of the tamponade are usually presence of a dyspnea, hypotension, and various other situations also. Now, if you are finding a large pericardial effusion, irrespective whether there is a respiratory variation is a sort of a non-specific sign. In 30% of the cases, there may be no respiratory variation in mitral velocities. So don't depend upon that also. But if other signs are present, then you can say that yes. But otherwise, we don't write impending. Either we say it is present or not, or we write the patient to be observed for any development of cardiac tamponade. But it is automatically then you have, whether it is large or so, you automatically put a pericardiocentesis also. So we normally write, whether we are able to see, we always write the patient needs a priority pericardiocentesis.
All right, let's say thanks to Parsha sir for his X-ray. I'll request Dr. Nurul Islam to present a small memento to Dr. Parsha.
I am a part of this center, then why this memento?
सर कुछ मीठा हो जाए उसकी बात कर रहे हैं.
Mare. My. बात ठीक है. इसके मुंह